Very good morning to you all. Can you hear my voice?
Yes, sir. Good morning, sir.
Thank you. Thank you very much. Thank you very much. I'm very happy to meet you all. This is the first class you are going to attend, I think so. So this is about, you can see my presentation, is it? You are
Yes,
seeing
sir.
my presentation? Okay, then. Thank you.
Visible, sir.
So this is about hospital information system. You can see the sliding. Slide is moving, isn't it? Hello.
No, sir, it's in first slide only.
First slide only.
Introduction.
Okay.
Yeah, now moving. Yeah, it's gone to third.
Okay. So we are going to have the first class. It's like it is about hospital information system. You know what is information? So generally, information is very important. It can be any type. Like verbally, we can create or produce or transform the information. Sometimes it is symbolic. Sometimes it is pictorial. So information in general, information is very important. So that is the kind of communication. So like the information can be utilized for the communication, or it is to acquire the knowledge, or it is to transform to from one generation to another generation. So many utility about these informations. But in the aspect of hospital, so we are very much focused on hospital information. So here, this is uh, we have got a lot of doubt. Why should we have to have the information in case of hospital, or whether the hospital must be equipped with the information system? Is that any norms for hospitals to keep the informations like that? So we are going to see that in this class. So what are the aspect of the hospital information system, why it is needed, everything and all. So before that, we should know the setup of the hospital. If you take the hospital, what are the different um, departments or different sector or different communities present in the hospital. So it is interconnected. All these departments are interconnected. Unless otherwise, there must be the transformation of the information one department to another department. There cannot be any synchronization, or they cannot coordinate with the thing. So all the departments in the hospital that is functioning, that will be focusing on the patients. All informations are for the patients, because they are giving the treatment to the patients. So it is related to the patients. uh, when the one patient or the group of patients are treated, these informations are utilized by the different departments that is present in the hospital. Okay. So we can say that it's wards are there, outpatients units are there, uh, service units are there, like diagnosis, and diagnosis mean X-ray department, and all blood group, blood checking, or radiotherapy, or like that. So many other services are there that is connected with the treatment or therapeutic regimen of the patient. Then administrative department, so they'll take care of all the workforce. They'll administer how all other departments are functioning, and above all, the management and executive units are there. So these are all the different departments that is present in the hospital. Then you can see the next slide, no?
No, sir. No, sir.
Yeah, okay. So what is hospital information system? So in this, no, we have to consider different groups like physician, nurses, administrative staff, technical staff, health informations, and the person who are all working on these health informations, patients, visitors, and suppliers. So you know who are all the physicians. So they are the main role player. So they'll take care of the treatment of the patients, and the next level is the nurses. So they are assisting the physician. So they'll be there in the outpatient department as well as the inpatient. So in here the outpatient and inpatient is the inpatient means the patient will get admitted in the hospital. So they will be taken care of inside the hospital. They'll not move out of the hospitals and all. So there are certain period, with that period they have to stay inside the hospital, and all the treatment and other facilities services will be provided to the patients inside the hospital. So they are all called inpatients. The outpatients will be they'll have a little problems or small ailments. So they'll directly come to the hospital and the outpatient department. They'll meet the physician and take the consultancy and take the assistance of nurses and pharmacists, and all medicines will be provided to them, and they'll leave the hospitals. So this is inpatient outpatients department, and nurses are all present and assist to the physician, to the inpatients as well as outpatient. Then administrative staff, so they are taking care of all other activities, administering purchasing and recruitment, and allotting the manpower to all the departments. And they'll take care of all other activities other than the clinical activities. The technical staff, they are assisting the nurses, pharmacists, as well as physician. So in three level, there are technical staff. The physicians, like for example, in operation status. So operation technicians are there. So they will be assisting nurses and physician. And in pharmacy, they are all technical people. They'll also assist the pharmacist in aspect of distribution of the medicines. So and diagnostic department. So there is also people who are all technical staff. So they'll provide the information or otherwise the supporting the paramedical staff members. Then in health informations are they are the managers who are making all other departments uh, what to generate the informations. So based on the input of whatever whether the registration of the patients and supply of the medicine and procurement of the medicine, or purchase of any instruments, and based on all these things they'll provide the health informations, or based on the diagnosis and based on the physician prescription and based on the pharmacist input, that is also they'll provide health informations. So it is all covering both. It is an administrative side as well as the clinical side. And finally, we'll come to the patients. They are the main stakeholders. Because of the patients, the hospitals are running. Along with the patients, there are people to visit. They are called visitors. They may be the consultants, or they may be the suppliers of medicine, or they may be the suppliers of any equipments. So they're all or otherwise they'll be accompanying the patients. They are all called visitors, the finally suppliers. So this is the setup of the hospital. So this is kind of a pictorial representation how this hospital information system is working out. So you can see that there is a registration department where from the beginning of the entry of the patient, so they'll go to the registration, they'll enter their informations, their details like name and the residence, the designation or the work what they are doing, and any previous medical history, or any other things, they'll register in that registration department. Then they'll be allotted a kind of token system or kind of registration number. So accordingly, they'll be sent to the based on their ailment, sent to the different specialized doctors or physician. For example, orthopedics are there, pediatrics are there, gynecologists are there. So based on the ailments of the patients, they'll be allotted to a different physician of the specialized person. So when next level, they'll go to that particular physician for the consultancy. If at all the patient is very serious, need chronic or disease, chronic disease, long-term treatment he needs, or something like that, he needs a supportive system, then they'll be admitted to the ward. Otherwise, they'll be given a treatment or consultancy, then send out as an outpatient. If at all they need a supporting system of the hospital, then they'll be admitted in the ward. Then in the ward, their nursing assistants will be there, so they'll support total treatment period. They'll take care of the patients uh, until the patient is get discharged after the treatment or after the ailment is cured, something like that. Then for all these things, no, like to run a hospital, you need so many things like if at all is diagnostic equipments to surgical. Like tools or surgical instruments, everything you need. So that will be purchased and that will be kept in the central store. From that, that will be sent to the pharmacy. From pharmacy, there will be a central store. From that, the nurse, the ward supply will be there. The nurse will get the indent, prepare an indent based on the number of patients admitted in the ward. So whether it will be like what to say, drugs or medicine or surgical equipments or dietary, diets, whatever may be the then supplements, dietary supplements, whatever may be, that will be taken from the central store by the nurse. Then after that, it may be like, and it is not over with that, so there'll be like other supporting department. As I said, like it may be blood bank or laboratory or radiology department or operation theater. So that is and all the supporting system for the patients. For example, if the patient is having the cancer, then they'll be treated in radiology. Then not only that, then the X-ray department. So like they'll take the, if at all anybody got fracture, they'll send to radiology department, taken the X-ray, and laboratory they'll take all the blood sample. Collect the blood sample and give all the details whatever present in the blood. Whether it is a count, blood cell count, or hemoglobin content, or the blood grouping, or any other details like lipid details, fat and protein details. Uh, so like that, all the content, whatever present in that, they'll give a diagnostic report. And blood bank is giving the blood, whether it is required during the operations and operation status that is supporting. And for inpatients, they have to provide the food. So for that, the diet and kitchen also there in the hospital. So this is the total pictorial presentation. Different communities present in the hospital. And here we can say simply like how from the registration it is until the person is admitted to the ward and the nurse is taking place and other supporting departments are there. So after registration, if that registration information is closed in that part, then there will not be any connection to these other departments. So from the registration, they'll pass the information to the concerned doctors or concerned nursing assistant, and like that it is passing through one department to another department. There will be a manager, hospital information manager, informatics, so they will connect all the departments based on the patients who are get admitted. So it is interconnected. So based on the treatment, whether he needs any diagnostic support, or whether he needs any radiological support or blood bank support, or whether he needs operation support. So like that, unless otherwise it is the information is passed from one department to another department, or it is synchronized, they cannot make the total arrangement of the patient treatment. So this is about pictorial. So we can this is another chart which will give you the idea, like what are the different communities are present. uh, we can say, based on the like department or the service provided, we can make that as a kind of department or the community. Like physician is one community, pharmacist one community, nurses one community, then the diagnostic radiological community. So like that, we can make the different communities. So they are all combinedly give the medical service to the patient. So this is the structure of the hospital community. So I'm just giving you introduction of hospital information system. That is why I'm giving total details about what are all present in the hospital and how it is connected. So otherwise, no, how the information is utilized, we cannot understand how the information is produced, created, or registered or documented. That will be utilized. So unless otherwise you know the basics of how the hospital is functioning, or what are the different departments are present in the hospital, we cannot say that we cannot understand how exactly how this information system is working out. So this is development steps of hospital information system. We can say that it is like clinical information system, management information system, and geographical management information system. So when we discuss about this, the clinical information system is like it is totally about the patients. So whether they are inpatient or outpatient, uh, it is their clinical aspects, like whether it is a treatment or diagnostic informations, or supporting services provided to the patients. All these things comes under clinical information system. Apart from that, who are all the physician involved in the treatment, and nurses involved in the treatment, and what other technical staff are involved in that treatment. So all these informations are comes under clinical information system. So management information system is they'll taken care of all the things, like from the procurement of the medicine, procurement of the equipments, and how they and, recruitment of the staff members, whether they are clinical and non-clinical, and all other information like supporting manpower, everything. They'll manage everyone, including the physician, nurses, pharmacists, non-technical people, technical people, other manpower. So they'll manage it totally, like, to run the hospital. So that is they'll also have the informations regarding everyone, like how many doctors are present in that hospital, what are all the specialization, and how many nurses are there, what are all their qualifications, and where they have been posted, and how many pharmacists are there, how many technical people are there, how many non-technical people are there, how many other supporting manpower are there. So all these information they'll keep. So that information will provide them whether the sufficient manpower is there to run the hospital, and whether the sufficient whether the recruited or all the appointment staff members have done their work properly, whether they are all synchronized, they are all coordinated, and they'll make it the monitoring the things how it is going on. So that is the management information system. Geographical information system is nothing but the place where it is present. It is very important, no? Like the patient's inflow is based on the population of the area or the community. So how many the old people are there? Geriatrics, they are all called geriatrics. How many children are there? So they are all called pediatrics. And the middle age and adults. So the population is very important. So based on the population, and they may say that what kind of service, what kind of clinical service can be provided to the that community. So this is called the geographical management information system. Then the information in the hospital. So this is what the pictorial way what I have given earlier slide, like front office where the registration is taken place. They'll receive the patients and visitors along with the patients. The visitors also come. So they'll take the informations from the patients. So this is the front office that will be present in the front and first entry of the hospital. And then doctor consultation room, it is besides the front office. It may be numbered or based on the specialization. Maybe it is orthopedic or pediatrician, or gynecologist, cardiologist. So based on that, they'll be given different departments and rooms and room numbers. So for the consultation of the patients, and whether it is inpatient means the wards will be there. It may be in the same floor or in a different floor. So here also the same way. Different wards are there. Male and female wards are there, or children wards are there. This is based on the gender, and other things is based on the speciality or the needs of the patients, like orthopedic department or cardiology department. So where only the cardiac patients will be admitted in that. So special wards are there, emergency wards are there, and intensive care units are there. So different ward system will be there. So that is based on the needs of the patients, the ward system. Then laboratory. So every hospital will have this laboratory. So this is the major supporting people. So earlier, the doctor used to diagnose the patient with physical, test. Like they'll see the inside the eye, whether it is pale or dark, or the color of the eye, something like that. Then they'll use a stethoscope to know the beats, heartbeat, and the sounds inside the body cavity. So the diagnosis is superficial. So nowadays, no, it is very advanced. The diagnosis is having super instruments, equipments that will give you the exact uh, uh, problem where it is. Like for example, scanning or there, uh, then uh, blood testings are there. So they'll take all the testings, then they'll interpret all these tests, whether it is radiological or blood test or any other ECG or EEG, that is electroencephalogram, electrocardiogram. So like that, so many equipments are there. CT scans are there. So all these equipments will diagnose the ailment and give the exact problem where it is. So these laboratories provides the diagnostic informations. Based on these informations, the physician can go for or start the exact treatment. So that way the laboratory will support. And service providers like financial and insurance service providers. Here in India, no, like the medical insurance or service providers are not that aware like other foreign countries or Western countries. There, the medical system or service is very costly. So unless otherwise, if you are told you are having the medical insurance, you cannot pay the bill of the medical services. Here, medical insurance, only the people who are all aware of it, they are going for medical insurance, or otherwise, any, the company which they are belongs, they are providing the medical insurance or medical support, medical support. So in that way, it is going on. So they are the people will support the patients in the financially by like the insurance, or they are the sponsors from the uh, companies or organization which they are belongs to. So here from there, here they are the people who are giving the informations from which they are receiving. Like from, as I said, the front office, there will be registration. So that is a kind of informations. After doctor consultancy, they may write the prescription or diagnostic tool, I mean, minimum diagnosis. So where they have to go for. Otherwise, they can write the laboratory test is needed or not. So all these thing informations will be from the doctors. That is consultation. Then they'll be admitted in the ward. Once they are admitted, they'll admit card will be provided. The case will be make ready. So all these are all informations in the case. Then in case sheet, all details of the patients will be there. Their name, their age, and their sex, and any other medical supporting things are there that will be attached with that, and what kind of treatment they are going to proceed with. So everything will be written in the case sheet. So this is specific to that particular patients. So that will be present in the ward. So the nurses will have these, access to these case sheet, and based on whatever written or whatever the progress is there, that will be entered in the case sheet. So now and then the nurses will check, and by checking that they will administer the drug or any other supporting things that they need. They'll send the patients from ward to the laboratory or operation theaters or radiological department. So everything is, like the informations will be recorded. In the case of ward, that will be managed by the nurses. Then laboratory. So once any patients have been sent to laboratory, they'll send along with the doctor's recommendations. So the laboratory people, they'll take up all the informations once again for the diagnostic process. So there also they'll make an informations regarding related to the patients. These then the medical insurance service, they need everything. Once they are entered into the hospital, the patients, after completion of their treatment, the starting to the end, whatever the information related to that particular patient, that will be accumulated. They'll take the authentication of that informations. Then based on that, they'll provide when the patient can claim the insurance from the medical insurance. So they'll check all the informations that patients provided. So they may go to the hospital or meet concerned doctors, cross check whether the patient have taken the treatment and what are the other services have been provided to the patients. Everything will be there documented in the hospital, that they'll cross check, and finally they'll provide the financial support to the patients. So once again, the information can be categorized, like it may be then image, text, video, lab values, sound. So image means the CT scan image, or what to say, the radiological things, that is an image only. So everything is an information. So it may be the image, or text means the content which they are providing regarding the patients, or regarding the service that provided to the patients, or whatever the other services are provided. Apart from the patient services, like the procurements uh, and other technical stuff, non-technical stuff, their informations, anything can be like the content of related to these services. Everything will be in a text form. and sometimes no, they for the sake of security or safety, they may go for a videographing. Like if any like for example operation is going on, that can be taken up as a video. That video can be utilized for teaching purpose, or it can be like for example say that the operations has been done in as per the procedure, or sometimes it may be like experts may be there in some other place, so they are giving the guidance to the people who are doing the operations. In that time they'll give a live video, so by seeing that video the other expert can suggest what to do, what how to proceed the operations. So for that the video information will be there. Then lab value, that is like as I said, like it is like diagnostic informations, blood samples, they, whether it is lipid value, fat value, or a blood grouping, are related to the blood profiles, everything they'll give those values. That is also like an information. And sound is like it is called a CT scan or sonogram, something like everything will be there. So that is a kind of equipment. By sound, it will reflect some of the informations that will be recorded. So, for example, ECG is like a heartbeat. That sound is taken up, and that will give you a graph. So that is a kind of information. So these are the different objects. How this information is translated, or it can be depicted, or it can be presented to the physician or patients or other managerial persons. So there are different way we can produce that information. So this is a simple model of hospital information system and data movement. So you can say that ward units and medical departments, patients administration, and administration logistics. So these are major four units. So from that, so many other supporting people are there. So how they are making it from the patient administration to the wards and medical departments. Then all these things be managed by the administrative people. So this is the chart, flow chart, to make you understand how the hospital information system is functioning, how the data are passed one department to another department for the utilization, for the administration, and for the functioning of the hospital. And now we'll see where these informations will be used. Uh, these are the different areas where the informations are utilized. One is patient administration, clinical management, resource management, financial management, and management information system, and more. So we'll see one by one, like what is the patient administration. It is like based on from the beginning, like how the patient is entered into the hospital, they'll go for a registration. So registration is the total detail about the patient. From there, where they have been moved, whether they are considered as an inpatient or outpatient, that is one information. If at all outpatients, how many times they have to visit after that first visit, and the date, and what are the who are the doctors they are going to meet, and what kind of medical service they will be provided to them, and whether they need any diagnostic procedures, and the medicine supply. So everything about that patients, that is the patient information. The clinical management means the physician. Once the patient is meeting the physician, so they'll take up the diagnose the patient, and they'll discuss with the patient what are all the problems they are facing. Based on that, they can suggest some of the diagnostic procedures to pinpoint the problem or to find out exact problem. Then once they made everything is ready, and they can based on the diagnostic informations, then go for the treatment, exact treatment. So in the treatment, they'll ask the patients to admit in the wards, or they maybe ask them to come every sittings, like next visit, or how many visits they have to come, I think, and all. They'll inform to the patients. So this will be circulated to all the departments, to the registration department, to the ward, or to the pharmacist, and to managerial push, administrative people. So these information will be circulated. So then only they'll come to know whether the patient is visiting, how many times they are visiting, what are the services they got, they are going to get it, and whether they have gone to diagnostic procedures, and what are the diagnostic services they have received, and what is the cost of those diagnoses, and who are all the person involved in the diagnosis, who are all the clinician or physician involved in the treatment. So all the informations will be go to the administrative department. Then resource department is like they'll take the resources of, like, for example, any specialized person is needed. For example, a patient is having the cardiac problem, heart problem. They are having pain in the heart, or the left hand is having the pain, or something like that. So they need a specialized physician for the treatment. So in that is the case, we cannot say that all the time all specialized special people or specialty people will be there, or experts are there in the hospitals. So that time they can go for a resource. So like any special experts in some other hospital or some other place will be there. They'll be asked for the consultancy. They'll call for the consultancy, or they'll come for the consultancy in a specific time or date. So they'll resource the experts. So not only the experts, they when visiting the hospital, sometimes the resource will be like the informations, like the guidance from the experts. That can be like a video, or that can be the call, oral, that can be the text form, or any other form. So these are all the resources that related to the patient treatment. Then the financial management. The financial management is like we can say that what is the investment they made for running the hospital. So they may have a ward system. So how many wards are there? How many beds are there? For that they need supporting people, technical people, non-technical people, physician, nurses, pharmacists. For that they have to invest to recruitment and management of these manpower. Apart from that, they have to equip with instruments, equipments, and medicines, surgical items, and some of the things are regularly they have to go for purchasing. As far as medicine is concerned, they have to purchase regularly based on the requirements of the patients. And blood bank, whether if it is blood bank is available in the hospital, they'll take that blood groups, and specific group blood, or otherwise they have to depend on the blood bank. So for that, for everything they have to like invest. They have to and it is when they once they invest, they'll take all the charges. Then they'll see that whether all these income will be managed properly. Once again, they'll go for salaries of the all the manpower, and any modifications, any alterations, any new equipments, or any new instruments. So like that, they'll circulate these finance. So unless otherwise, it will be circulation once. It is not one-time investment. So every time they have to invest, every time they have to spend to procure so many things. So it is like the financial management. How they are managing the finance. to run the hospital profitably. So that is financial management. Management information system, like it is overall, like patient, clinician, nurses, pharmacists, other technical, non-technical stuff. So they'll manage everyone. As I said, like the information will be passed on to the other departments. They'll synchronize, they'll coordinate. So finally, everything will go to the administrative office, so that they'll come to know total cost of once one patient is, get into the hospital. Since he is leaving the hospital, what are the services are provided, how much cost has been incurred. So like that, they'll make a total audit system. So that is the management, the administrative system. Okay. So this is like how the database is produced. Database is produced, uh, like from the different department. The information is received from the different department. Like for example, from pharmacy, from laboratory, from radiology, then patient database is the database is interface. Then event monitor, medical logistic, billing, specialized, specialized medical services, like that. So many other departments are different events are there that will be taken up and produce the database related to the patients. So this is database interface, where from they are getting the information. This is depicting how the information is received as well as given to the different departments. So it is like interchangeable. So like that, they'll collect all the informations, produce a database of the patient. So once the patient registration number is clicked, the total information will come out, like how many times they visited the hospital, who are all the doctors they have consulted, and how many times they have been tested for diagnostic purpose, and what are the medicines that have been provided, and what are the surgical procedures are provided. So all the informations will be taken up from the database. Well, this is a summary. We cannot say that it's a conclusion. It's a kind of summary. What we have so far, what we have seen, like it is integrated or related. It is interaction between so many departments or components. So that is only making this hospital information system. It is not one department is producing the information. So because so many departments are available in the hospital, so many events are taken place once the patient is entered into the hospital. So all these informations will be collected and produced as a database, and the person will keep all these database for the continuation of the uh, service to be provided, or service already provided to the patient. So whether it is past information or present information, or what they are going to do, that is also an information that may be in a text form, or say image form, or a video form, or any other diagnostic form. The values. So every information will be made as in a database. It is interchangeable, interconnected with all other departments. Then so once we are making a database, means it is not like it may be like a paper based or computer based. So paper based needs a lot of entries. So they may have format for the paper based. For example, what means they'll have entry for the individual patients, like as I said, the case sheet. So it is having the kind of format, name of the patient, sex of the patient, and the age of the patient, and what kind of the treatment they are taking place, what has been diagnosed. So all these things as a kind of a format, that format will be filled. So if at all is a paper based means they'll have a format. That format has been filled up. Um, Otherwise, the same format may be in app system. It may be in application. In that they'll enter all the informations. So that app will produce kind of total database. So whenever we are clicking on the patient name or the registration number, whatever the informations we need regarding related to that patients will be taken up from the database. So it may be the paper based or computer based. Digitally it may be entered. So the technology can be utilized for the informations to be stored. So we are going to see how so many things are going on in future. This is a summary of how this hospital information system is working on, based on the service provided to the patients. Then we can say the functions, as I said, the functions of hospital is like laboratory, pharmacy, and doctors, financial and administration. So many functions are there. So it can be detailed. Deal in detail in future classes. And I may take in the first unit only the few topics, maybe the importance of this information system and how this information system is having the impact on teaching and learning. So only few topics I'll handle in the hospital information system. Uh, I think so far whatever we have discussed, uh, whatever we have discussed, I think it has reached you. You can raise your doubts in the comment box. So I'll go through that thing, uh, and then provide you whatever the clarification I can based off my knowledge. I hope you can understand the total picture of hospital information system. Thank you very much. Thank you very much for listening. So it's a wonderful thing. Like I feel so to provide you the hospital information system icon information. Thank you very much.
Sir, excuse me, sir.
Tell me, please.
What about EMR, sir? Electronic medical records.
Yeah, that is a different topic that we are going to handle in future classes. This is only the introduction. So I have covered only how the things are going on in the overall the hospital. So the health medical records, electronic medical records, everything is a topic that we are going to see it in the future classes.
Okay, sir. Thank you, sir.
Thank you. Thank you very much, sir. So I'll provide you the materials in later. Whether you need a material from only the PPT that is also is there with me, or otherwise the running content also there like chapters. So all these things I'll provide, so you can make use of it for your examination purpose. So this is a kind of brief how the things are going on in each topic or each hospital information system of each topics are things and all. So I hope it is being is a first class and beginning of the course, and in particularly the hospital information system. So I have given a basic idea of hospital system departments and how the informations will be interrelated, how the people are going to connect it with each other. So based on that, the informations will be created. So those informations will be synchronized and coordinated. And later on, we'll see individually like how each department is creating the specific, like for example, electronic medical record. That is an information. How important that electronic medical record or electronic health record, EHR or EMR. So that is a separate topic. We can in depth we can see how these electronic medical records are produced or made available, or what are the informations are available in the electronic medical records, and how it will be utilized. Everything will discuss. Anyway, thank you very much. Thank you very much for patient listening. We'll meet in next class.
Sir, good morning. Hello, is it audible?
Yes, sir.
Okay. Shall we start, sir? Yes. Able to see my slide?
Yes, sir.
Okay, so thank you, sir. Uh, I think now we'll continue with this total quality management, why it's a record, and all when it starts from the thing. Last class I was discussing. I said that we need to total quality control is necessary. Last 70 years we are pursuing. It starts in the year 1940s. So 3 points we need to take away. I said in the last class while discussing. I said 3 points need to be taken in the consideration. One is totally everyone involved in this total quality management. Second point is uh, the long term we need to work for total quality management and consistently produce safety and efficacy of the consumer. Whoever the consumer is, the patient is the consumer. We are following the guidelines of 6 guidelines. I said Q8, 9, 10, and 11, 12, 13. 11, 12, 13 yet to implement. These three are we are focusing in the future perspectives. But remaining things we are working on Q8, 9, 10. So now everything is a total quality meant towards the development of pharmaceutical product developments. Pharmaceutical product development in the industrial area, the concept we should understand by the help of product development to how to implement in the hospital management. That is the way we need to go for the study, because it's a statistical design how we can implement into the product development. That part we need to learn, then it will be implemented into the our studies. At last class we discussed the why it's total quality management is required. So now we'll continue the thing. uh, actually that three stages are involved in the process validation process, that is process design by quality by design approach, then process qualification, how need to be validate, that is and all the pure validation part we no need to consider, but the what are the three stages involved in this, these are the three stages involved in the exam point of view only we need to learn this. Then what is the timeline of quality by design approach when it's started? It is started from 1987 to FDA, Food and Drug Administration, come to the picture after this quality issue started. Quality issue started in the year 1940, almost uh, somewhere around 80 years old. The quality concepts came, but the quality concepts and gurus comes in the year 1950s. 1950s the quality gurus are there, we are going to see now. Some three people are very very essential. They implemented the concept of quality, why its quality is needed in everywhere, so that they given in the year 1950s. From that, the Food and Drug Administration Act, that healthcare team created the guidelines. Based on the ICH guidelines, we start to work on it. So when it started is 1980s onwards. 1980 onwards, we able to follow the total quality management process. The first drug comes out by using that is in the year 2013. So almost 50 years took to develop a total quality in the farm industrial area. So it's almost 50 years, the 5 decades worked for quality, total quality management. Then quality by design approach, it started. The quality by design approach, it's nothing but the how their quality is planned, designed, and the experiment performed, and checking of quality control. This all the strategic approach, that is the remaining nothing. So based on this approach, we are going to how we are manufacturing drug. The same thing we are going to implement in the quality aspects. Now we'll see this when it's what are the benefits of TQM we need to take. So by total quality management, we can improve the quality of the product. So from the starting, we are telling the quality. The quality is consistency, efficacy, and safety. These three things should be satisfied. Then automatically the customer will be satisfaction will get. By this a fifth point also, customer satisfaction. So when we are improving a quality for concern, see one example I'll discuss here. If a patient taking a medicine, what is the feeling he will when it will be satisfied? He has to recover as early as possible with a minimum side effects. At the same time, you need to be a affordability cost. So that if able to produce, then he will be very happy. The customer, when it will be satisfied, the by means of he is recover from the disease, whatever may be a disease, as early as possible. That is the potency, the efficacy we are discussing. So if I am able to recover as early possible, then I will be happy. Then second point, I am able to affordability, cost factor involved. Then availability. So everywhere, if immediately I should get this, all will comes into the picture for this improved quality. Then the safety is need to be assured. I am not getting any side effects by taking the medicine. That is also very very essential point. If able to satisfy this, then the product will be uh, uh, sustained in the market. That is why the first thing is improved quality for long duration of period. So that when you are improving step by step the total quality, it definitely a product will be in have a high quality, then automatically it will be written in the market. Then employee also participation. Employee participation, we discussed it. Not only a quality control team or quality assurance team, it is involvement. Already we discussed this. Then it's a teamwork. Third point is teamwork. So now you cannot blame a one person who is the responsible for this. So everyone, so from starting to end, whoever involved this, everyone together work. When you are together work, manpower and materials all will be put together, will make it a quality things. Then many people involved with the brainstorming session may give beautiful ideas to improve the quality. That is why the teamwork is essential. Then working with the relationship, who is their responsibility? We have to train the staff members who are the audit goes, who is the checking points, that is quality control team, who will assure based on the database. That relationship need to be established to satisfy the quality perspective. Then automatically customer satisfaction, for that only every point of view we are adding. Then employee also satisfied, so he is also need to satisfy by producing a quality product. The productivity, every industry wanted to make their profit, because every industry we need to minimum input, that is optimization will come to the picture. They want to minimum utilization of things, then maximize their productivity. So with quality and consistency, communication to every individuals to ensure the quality. Then from that already I discussed that profitability. So whenever any industry is manufacturing any product, they will look for profit that need to be attained. When it's a quality only able to withstand in the market to produce a profit. Then market share in the sense market, how it is shares all happening. These are the points you need benefit of TQM. So when it's a quality management, it starts already. I said that it is in the year 1980s onwards. It just started the quality TQM, but the Ford Juran is a person first discuss about the what is the quality and what need to be done. Everything discussed in the year 1950s. So the quality concept starts in the year 1950s, but it is established in the year 1980s. From the start in 80, we are working on need to produce a quality products in the market. So first initiated by this Japanese, followed by Americans involved in this. That is, it says this graph will show that quality, how it starts, when the tools, what is the methods comes to the picture. In 1920 to 40, by inspecting the product, that is checking the product whether it is quality or not, we need to check. That is quality control tests, they may call us. At the time they went for that end product, they will go for inspection whether it is suitable for the patients. When it is completely satisfy the customers, they will allow into the market. If fails that, they will be reject and reprocess will be start. 1942 to then 1960, the statistical process comes into the picture. That is prediction, hypotheticals. So when you are keeping these conditions, we able to produce a quality product. That hypothetical statistical procedures involved to improve the product outcome. That is your quality product, how you will get. For that, some statistical approach started to use in the year 1940 to 60, that is 1950. 1960 to 80, the improved designs. What are the newer designs? What is the methodology we can adopt to design? So simplified design, the error minimization designs, the planning of works, it started. The planning of design, you will get the understanding of product knowledge and process understanding. These two put together will able to design your experiment in the quality manner. That is called as the year establishment of total quality. In the year 1960 to 80 it starts. Then the quality through designs is come to the picture. Then the quality through designs is started is when the what are the designs I am able to make, that I'll go for evaluate by the statistical design of experiments. That is quality by design approach. It's come to the picture. That is involved in this PSDA, that is the plan, design and all. We'll come to this the next slides, we will discuss that period. It started the quality through design. It's the quality by design approach it came. Then last 20 years, the total quality management is completely taken the picture. TQM and QBD come to the picture. So here only we are going to discuss about total quality management, why we are implementing, what is the need in this scenario. So these are the beneficial. The beneficial in the sense the benefits include lower cost, higher returns on sales and the investment and ability to charge higher rather than the competitive prices. So nowadays, I think in the market potential of drugs, the Drug Price Control Act also came. So some drugs examples. So if you are manufacturing atrovastin, you cannot keep your price for whatever you want, because the drug price control will come to the picture. You can restrict up to 65 or 70 rupees. You can any statin, you can go and check it. Only 10 mg or any statins, only 60 to 65 rupees only we can keep, because the price control will come to the picture here. So then you need to make profit within the market level. If you want to go for keep your away from the price control, if you want to go for newer technology or newer combinations, then you can go for your price for the profitable. So that is why, so with that limit, you need to prepare your quality with compromission of your profit. This essential is required. Then another one is time record for new innovations. See, I think you might know that a drug molecule come to the market, it will record 10 to 15 years, because this it has to pass all the three phases of phase 1, phase 2, phase 3. Phase 1 is the development period, phase 2 is the clinical trials, preclinical and clinical trials, then phase 3 is toxicity studies. After the three phases, only the drugs come to the market. So any drug involved in the 15 to 20 10 to 15 years, the cost definitely will be come to the picture in that. So that is why we need to reduce the time requirement to develop new innovations, will always help to produce a low cost product. A total quality management is a one such approach that seeks to improve quality. So we are going to discuss here only quality. About the total quality management is only a quality how I can improve. That is TP will come to the picture, then CP will come. So all will discuss the coming slides. These are the benefits of TQM. So this is also same, other at lower cost, the other way of explanation. This is all for your exam point of view, if you want to add the points. Here, as a healthcare team, why I should study about the total quality management. This only one slide, we need to understand that why we wanted this. See, actually, in the each year, between 5 to 7 and 8.4 million people are dying due to poor quality care in the low and middle income countries, counting of 15% of overall death in these countries because of low quality products. So quality products, not only a products also come to the quality care. So that is quality care in the healthcare system. That means, so poor healthcare effectiveness is there in these countries. So you can, this is the 2023 statement. You can see this. This means you will be accurately diagnosed and treated in some countries is only 35% patients only correct diagnosis happening. So any one hospital need to improve the correct diagnosis, accurately diagnose, and for the treatment for that, if able to treat correctly 100% diagnosis and treatment, then the death rate will be greatly reduced. This is the 2023 statement. These are the reason we need to implement, where you can effectively implement that the quality, in the sense of the quality of healthcare is effective, the safety, timeless, then equity, then integrations, then efficiency, then effectiveness. So these are the things we need to consider in the healthcare total quality management process. That is why we need to incorporate this TQM tools, what we can learn into the hospital, that is management, wherever the healthcare teams. Now we'll discuss about what is the quality gurus. What is meant by quality gurus? A guru, by definition, it is a good person, a wise person and teacher, be able to discuss and explain the quality perspectives. A quality guru should be all of these plus have a concept and approach to quality within the business that has made a major and lasting impact. That is major impact who is able to create in the perspective is called as guru. So we call it as quality guru. These gurus have done and continue to do that in some cases even after their death also we are utilizing. That is, we are going to see. So in this quality gurus, we may call the 7 gurus are there in the quality gurus. This all exam point of view, you need to keep this points. Then era of quality gurus. The as I said, in 1940s the quality gurus are starts. 1940, then 1950 Americans who took the messages of quality to Japan. Then late 1950s, Japanese who developed a new concept in response of Americans. Actually, here 2 points we need to understand. The first initiation, the 3 people went to Japan for quality perspectives. Then after these 3 Americans went to the Japanese started to respond the quality. The 3 people came to the things. Then in the 50s, then after 1970 and 80s, Japanese Western gurus also followed Japanese industrial success. In this, 3 people are very, very essential for these things. Deming, Chauspri, and Juran. 3 people. These 3 are made the clear thing. Among this, right now we are using Juran, the person we are following. Actually the Juran in the Japan invited to. He's an American. He invited to Japan in the year 1954. Then Union Japanese scientists and engineers, Jews they may call this, that they invented in the Juran to create a quality concepts. He predicted the qualities of Japanese goods would overtake your quality products into the US by mid of 70s, because the Japan revolutionary rate is quality improvement. So that is why already we discussed Japan is the birthplace for quality. The well-known things. Based on this product implement by these Japanese, the revolutionary starts in the other countries too, including US. These are the 3 Americans went to Japan. Edward Deming, he is a very important person. These 3 are we are discussing: Edward Deming, Juran, and Armand. These 3 people went to Japan in the 1950s to initiate the quality concepts. Among this, Juran and Deming are very, very important. Then Japanese who developed new concepts in response to the American. So these American went and initiated the quality perspectives in the Japan. Then the Japanese also started to work on the quality. They produced some concepts in this very important person. Till now, we following Ishikawa, that is Karu Ishikawa. Ishikawa developed a cause and effect diagram. We are going to discuss. Other 2 also worked in this, but the major role plays still we are following the Ishikawa rules and regulations, that 7 concept in the quality controls. That only we are going to discuss today class. Ishikawa, what is the statement says that we will discuss. So this is the Ishikawa states. So he initiated the many contribution to the quality. He only started the quality by the most of noteworthy being in the total quality viewpoint. So company wide quality control gives emphasis to the on the human side of quality. The Ishikawa diagrams, actually that is called as cause and Ishikawa diagram. The name itself called as Ishikawa diagram. Then another one they may call as cause and effect diagram or fishbone diagram. I think you can see the diagram. See here, this diagram you can able to see this diagram. So this diagram is called as cause and effect diagram or fishbone diagram or Ishikawa diagram. This will give the clear relationship between your problem and what is the factors involved in that what are the factors you need to be, that is where you need to improve your quality aspects. That is the very, very essential point. So this will give you clear picture in that. So these are the things in this diagram initiated by the person name called as Ishikawa. Then the diagram name also called as Ishikawa diagrams. Not only that, he said that what is meant by Pareto analysis, where we can use this Pareto analysis, cause and effect diagrams. That is the I said. Then starifications, then check sheets, histograms, scatter charts, and process control charts. These all involved in this given by Ishikawa. So the quality perspective, whatever the points we are going to discuss now, whatever the point we want to improve, everything will be discussed in the relation with this Ishikawa methodology tools. That is, these all called as tools. These are called as tools to use the total quality control. They may call the 7 tools. They may call us 7 tools. These are the 7 TQM tools. I think I already said this all given by Ishikawa. Shishikawa only given this. This is quality control tools. They may call us not only a TQM tools. They may call us quality control QC. The QC tools they may call us. With correct implementation of 7 tools, 90% of quality related problems can be solved. So this, if you are implementing in any organization, that may be a hospital, healthcare team, or industry, or automobile industry, or software institution, anywhere, any place. These are the place you need to concentrate that to work how to correct it. These are the things. So I think this 7 points we are going to discuss today. What are the points? We'll see. Number 1, check sheets. Number 2, histograms. Number 3, scattered diagrams. Number 4, control charts. Number 5, run charts. Then Ishikawa diagram. Then Pareto diagrams. These are the things we need to discuss. Here, whatever the points I given in the written text, you take it as a your exam point of view, preparation, examination. I'll share the slides. Now I want to show this check sheets. So first, one by one, I'll discuss. I'll explain the check sheets. Then the check sheets will normally go help to planning of your experiments. So that is everywhere we are doing. So nowadays, every point of view we are like checklist or check sheets we are pursuing. Checklist. So what are the things to be completed today or this month or this week? We are making a planning of work. So plan. So then this will help you to understand where to start the work, how to complete the work, all the things. This planning of works. This planning of works will start by what are the works to be completed, works to be taken. The stepwise you have to list out. Then wherever the possibility to understand that, wherever the possibility to concentrate your work, where the chances of errors may be happen, where to collect, then what is the sequence I have to go, then all will be come to the picture. Here the process also will help us. The 5 years program is there. That 5 years we'll discuss in the after completion of this. The 5 years will be come to the picture. So here first we need to understand that what is the checklist or check sheet. That means I have to list out or note down the process happening. See one example. If I am performing a tablet, manufacturing a tablet, the tablet weight should be 500 milligram. So I need to perform the analysis of 20 or 25, 20 tablets. I will go for weight variation test if I am performing. So I have to note down first tablet 499 milligram of that is tablet is that. See actually total weight may be 700 milligram. The tablet, for example, if you are preparing a paracetamol tablet, paracetamol contains 500 milligram in the sense the tablet weight will be around 700 milligram. So if I am take it as a consider as a 700 milligram product I am preparing. Some product may have exact 700 milligram. We cannot be prepared all the products. If your tablets are there, some slight variation will be there. See, for example, if I am preparing collecting 20 tablets. I am measuring the 20 tablets. 20 tablets. What is the points I have to check it? So total weight. So one tablet may 498. One tablet may be 499. One tablet may be 500. Like this, I have to note down. So we have to segregate for 498. What is the how many tablets? 499. How many tablets? 500. How many tablets? You have to make list. This all tally sheet or table check sheets. That is the thing. If you are because every you cannot assure that I am able to manufacture a tablet all exactly 700 milligram of tablet. So slight variation will be there. So I have to note down how many tablets are in the 700 milligram, how many tablets in 702 milligram, how many tablets in 698 milligram. That you have to make and note down. No, this is called as check sheets. Another one example, we are taking our family rice pack, 25 kg rice pack we are taking. Every if you are consider some 100 packs, if I am to manufacture today, packed 100 packs, if I am weight variation, weight checking, if one may be 25.200 milligram, 25.100 milligram, or 24.950 milligram grams. So these all kilograms that it will be varies. That varying points you need to note down. That is called as data sheets. Any companies, any industries, they may have groups, subgroups, databases that is called as check sheets. That is the number one. If you are having a check sheet, you can easily understand that where I can need to be improved. That will be clear. Then second tool is histograms. So these histograms and the bar diagrams, it looks like a bar diagrams. I think many people may understand clearly. Histogram and bar diagram is slightly different. It looks like a bar diagram, but this is slightly different from the bar diagram. So that means, see, we can group wise a single data, we can set into the groups. That is called as histogram data. So the same thing, I am different individuals. If I am comparing and studying, that will be a difference. See, same industry, manufacturing, different kind of tablets. That will be, if I am tabulating in the graph, that is called as bar diagram. So in the month of October, how many units I manufacture paracetamol, how many units manufacture in the bicalitamide, how many units manufacture in the streptococcus. So like this one drug, if I am discussing, that is called as bar diagram. We can make it like the same thing. Yeah, only one drug if I am taking paracetamol. So in the month, what is the first month it's taken? First 3 days, how much paracetamol if I am taking? The second, the fourth to sixth day, how much units of paracetamol if I am taking? So the same data I am grouping. That is called as histograms. That will be gives a very clear understanding that what in the same data where I can get the best output point. Then what is the condition I use that I'm able to produce best output. So that places I need to work. So as I said, even previously one example I said, no. So the rice pack, 100 rice pack I checked. So how 25 kilograms, that is kg, 25 kg, how many people time I am getting? Definitely major part of things I will get 25 gram. So you can classify like this: 24 to 24.5 grouping, then 24.5 to 25 one grouping, 25 to 25.1 grouping. So then how many packs come to that? Then you can draw a diagram that is called as histograms. These histograms will will give you a clear information about where I am using that falling into the group, which conditions is that my product is, how quality it is able to produce. Then you can understand by how much it is falling down. If many people falls in the lower cadre levels, that means low levels and high levels. In the case 26 kilogram, if many packs comes, then the quality in the weight management is failure. If 24 kilograms, that is also I need to face the problem. So because there I have to correct it. This easily we can understand this by these histograms. Then third one is scatter diagrams. Scatter diagram now always will help you to easy understanding about the concentration. See, here 3 points you need to understand. One is linear. Linear, everyone knows. X-axis, by increasing x-axis, y-axis is increasing any data, that is called as linear. Increasing, that is positive coefficient. They will discuss in the graphs. When I am increasing in the x-axis, see, for example, if one industry, many people they are appointing, their output is increasing, means that is having a positive interaction. That means I am increasing a staff number, increasing a staff numbers, then my product output is increasing huge. That is called as linear positive interaction. These two are having positive interaction. Staff numbers and product output having positive interaction. Linear, maybe a linear or non-linear, but it is increasing in the sense that is normally it will be increases. So that means when the positive interaction have between these two factors, factor in the sense what is the number of staff increasing and product output. So this will help me to understand this clear picture whether it is in the interaction between factor A and B, that is salary, staff numbers and product output. You consider another one. So if the same thing, it is in the increasing line, is that it is a positive interaction. It start to decrease, that is called as decreasing. So the decline, that is negative interaction between factor A and B. So that is negative interaction, maybe a possible is there. So if I am able to decline the situation, that maybe another graph is that. No. So that is when it start to decline some point of time. If you may increase your values, sometimes it may decreases also. Decreasing manner, if it is comes, that is called as negative interaction is there. Then another one. So the one is positive interaction, another one is negative interaction. That is the correlation relationship between factor A and B, two factor X and Y axis. Anything I am increasing in the x-axis, if it is increases, positive interaction, positive correlation, they may call it as. If I am increasing in the x-axis, it is decreasing in the y-axis, that is called as negative correlations. That means that these two factors are having negative effect. These two are positive or negative effect. And one more effect, you cannot consider positive effect or negative effect. So that means you not have clear cut idea. So it's widespread. Here one data, here one data. This is no correlation between factors and A and B. X-axis increases, y-axis also increase, sometimes decreases. Both is possible. Then it is scattered diagram will help us. That is called as non-conclusive. Non-conclusive will be there. That is the third one ideology is that. So three views here will be there. One is positive interaction. Second one is negative interaction. That is negative coefficient. The third one is we're not able to conclude that because it is going to give the information that where my data falls in various perspectives. Both positive also may be there, negative also may be there. Not because of x-axis and y-axis put together. So whatever the points I am able to correlate, it may vary. In the chemistry, they may call it as structure and the activity have direct relationship. They may call it as SAR. They may either you may study it or not. Structure of the compound, activity of the compound, it is have the relationship When if you are changing the structure, the activity will be altered. When the activity need to be changed, the structure of the compound need to alter. That is having a positive relationship. The positive relationship it's there, it can be changed. That is the way we are doing. This is the help of scatter. There's 3 points tools we studied. One is first one is a checklist or check sheet. Second one is histograms. Third one is scatter diagrams. Then fourth one is control chart. I think I given you two diagrams. So I already we discussed this control charts points because I'm not may not be able to produce exact 700 milligram of tablets, all the tablets. Some tablets may vary slightly to the lower level, slightly to the upper level. So that means when I am able to produce a product, some extent level will be acceptable limit will be there. That is called as lower acceptable level. That is lower control limit. I think you can see here the two dotted lines, red lines will be there. Upper control limit and lower control limit. My products are fall into the between this upper control limit and lower control limit. Means if it is that product is acceptable. If sometimes it goes out to the upper control limit, then I need to work on it. Why it is going out of that is alarm. So it gives alarm that it's your product is not satisfied with the quality perspective. It is going out of the control limit. So then I have to correct it to bring down the control levels. So these are the point will be help to understand the control chart. Here, then another one more point in the sense of medical terminology, for better efficacy, we need to produce the drug treatment in the like same situation. The therapeutic window may called us. Once we are administering a tablet into the systemic circulation, it reaches to the systemic circulation. That is called as bioavailability. That bioavailability will be between the therapeutic window. So if you are taking a tablet, we need to produce at least that lower concentration, how much to inhibit the pharmacological action. So this simple example I can explain. So if you consider if you are adult, you need a tablet of paracetamol at least 500 mg or 650 milligram to inhibit the pharmacological activity, reducing body temperature. So paracetamol is a example I'm taking, well-known drug. It is an antipyretic drug. It reduces body temperature, for example. So if I'm taking a 100 milligram of drug for my adult, for me, it means that it is not enough to at least inhibit the therapeutic activity. That is therapeutic window. It's not met out. If the same concern, one pediatrics, if I am giving 650 milligram of drug, that may be a toxic to them. So that means the upper limit it will be crossed. So that is that the drug dose is higher. So that therapeutic window we need to maintain. So that is the maximum concentration level and minimum concentration level. In between, you have to maintain your drug. That will be produce therapeutic action. Same like this. So is similar. That is the things. So I am telling when you are able to draw a control charts, the control chart will give you clear indication about the will give you clear indication about that your product in the controlled manner. So when it is in the controlled manner, you no need to do any correction in that, even though it is in the slightly zigzag position is there, ups and downs is there, but it is the control level. So that it may not be a wide range of lower and upper. In the these two between very closer will be the range. Say for example, already I said that if 500 mg means 498, then 502. This narrow range only will be allowed. We'll keep this range as a upper limit and lower limit. You have to plan accordingly to prepare a control strategy. That the control strategy will be followed throughout the cases. What are the products you are manufacturing? You need to check in that then you can easily understand that whether it is available in the controlled manner or not. That is things. This will be helpful to understand the control chart. Then another one is run chart. This run chart also like a control chart is similar to control chart, but it is a only slightly you can vary that upper limit and lower limit will not be there in this. So that is the case study of this run chart. Run chart may also similar to this all the parameters you need to make a what is the database involved in that. But only thing is the control and that is a upper and lower limit may not be fit to the run charts. I'll come to the main part. This I need to discuss a lot. The cause and effect diagram. So this is a very, very, very essential point in this scenario of total quality management. Here they may call it as 5M1E. 5M in the sense men, material, measurement, methods, and machines. This the factors will incorporate into the problem solving. Then one is environment. What is the conditions? That environmental condition will help this. These are may generally in the industry they may call dust, but it's not only this 5M only. It may cause any type of problem. You can see that red color, the right hand side, that fish head. You can keep your problem. What is your problem? Whatever it may be, you have to keep that side. The remaining the factors, what are the factors in one? Any number of factors, not only 5 or 6 or 10, 20 or hundreds of factors involved in that. Everything you can list out. By how I list out? That is why we need to discuss this. So this is the way we need to work. Planning and designing of your experiment will come to the picture. See, for example, as I said, your problem will be the fish head. You consider fish bone. This is the fish bone. The remaining things, all the tons will be consider as a one factors. The factors may consider plenty of sub factors. Plenty of sub factors. It may be hundreds, 200s, any number, maybe. So this your problem will be in the right hand side. All the factors, what the problems, where the facing issues will be in the left hand side, where you have to keep the adjustments is needed. So the normally this we called as factors. Then the right hand side your problem will be response. If you want to analyze the response or you want to attain the response, you want to get a quality response, then you need to adjust these factors. That is already I said that SAR structure and activity having direct relationship. Same thing here. So when I am changing the factors, whatever the factors involved in this, if I am able to change, the problem of my response will be altered. So dependent and independent variables they may call us. So the terminology also very, very essential to understand. But anyway, here the Ishikawa is called as a Ishikawa diagram, cause and effect diagram, or fishbone diagrams. So this will help me to identify the critical parameters involved in the problem process to produce quality products. So sorry. So that is why what are the problems involved in this? That is factors where I can monitor or where I can make changes, where I can able to correct it. That will be kept in this left hand side. That is called as our factors. What are the parameters you need to verify? What is your problem? What is your final achievement, target profile, target product profile? Anything that will be in the right hand side. That is called as fish head. This having direct relationship. This need to be identified. What are the factors in that? How I identify? Then you. This is what called as brainstorming session. So that means whoever involved in the process, manufacturing process or hospital management process or industrial software engineering, what is the software developers or everywhere, automobile engineering or anything, wherever you have to incorporate all the people to discuss to for the create a brainstorming session. They may call it the healthy discussion need to be done on this. So the based on the healthy discussion, you need to go for preliminary experiments. So some experiments you need to perform to understand the factors and the response have the relationship or not. For example, when I am able to understand that relationship, when I want to improve the mileage of my vehicle, I need to work on the engine of any vehicle. Say if I'm, you will take it is like this. Say I have a new bike. In that I want to enhance the mileage of my bike. What I have to do? So plenty of things I need to carry out. One thing is I need to engine. I need to adjust carburetor. I need to adjust. This the way I can enhance the performance. That is mileage I can enhance. So the right hand side the response I will be a better mileage. So what is the things directly influencing in the mm, mileage of the particular vehicle will be list out. That is called as the factors. That is called as factors. So these factors will be listed out. Not only a one factors, it may have plenty of factors. All the factors you need to identify. When they identified among this, which is have more influence, that you need to be identified. That is called as critical parameters. That critical parameters, by keep changing that, my response will be altered. So when I am adjusting the carburetor, then mileage will be sometimes it will be very high. So I want to enhance the speed. So though I know I need to compromise my mileage, so that I need to adjust in the carburetor for better performance by not enhancing the mileage, I enhancing the speed. So that is also I need to work on it. So that is why, like that, you need to take care your problem in the fishbone diagram. So why I am taking this elaborately, this is the things you need to understand. Any type of research, any type of management start with this place. Ishikawa diagram will help us to understand. So that is why, even if you are HR department or wherever it may be, list outing that problems. Though the Ishikawa diagrams may will help you to where it will be. You need to concentrate, focus your things. Theoretically, it may produce some points. These are the points you have to take it care. So when if I am preparing like a nanoparticles or anything, by increasing a rotation per minute speed, that automatically speed increases, the particle size will be decreases. So normally, so that theoretically I know, but I have to perform some preliminary experiment whether it is follow the theoretical aspects or not. I need to confirm that. Then I have to go for producing that parameter as a critical parameter. By next level I have to change some lower level, some higher level. Within the period I have to perform the experiment whether is it possible to solve the situation or not. By keeping the change in the critical parameter concentration, that is called as design space. They may call it as design space. That design space only we can work in that. See, for example, where I can start, where I can end. That is called as design space. They may call us. See, for example, if one consider a example, if I want to manufacture a tablet, some particle size, if I want to produce particular thing, then I rotation per minute RPM will plays significant role. Means where I can produce a particle, that is called as a minimum level I have to work. Then where I can go for maximum keep, that is maximum level. These two levels I can produce a quality product. That I have to consider this the two levels. In that, which is the best level I need to identify. That is in the process by statistical optimization method. But this level identification and factor identification will be identified by the brainstorming session involvement of all the faculties or employees in that your organization, whoever it may be. You have to bring out, you have to train them, you have to ask them to list out what is the better way to enhance the particular aspects, then list out the things, the common points need to be addressed, then that removing of significant factors, identify that factors you need to possibility to modify to enhance the your response. That is the way the graph is very very essential. Any type of research in the concern nowadays, in the any type of research if you are going to perform, you need to first identify the problems. What is the problem? That is your research problem. What way I am going to work, what are the factors involved in that, then how I will be go there. So this may called as cause and effect diagram, fishbone diagram, or otherwise it is called as Ishikawa diagram. This Ishikawa diagram will help you to understand the relationship between the factors and the responses. So when I am able to understand the factors and response relationship, then I can minimize the errors or improve the quality aspects. So it's a continually, if I want to improve, I can utilize this. This is the way. That's that. Another one is Pareto diagrams. So the next method tool is Pareto diagram. It's nothing but it's a graph will be like this. They may call it as 80-20 percentage. See, 80-20 percentage, when you need to diagram what are the problems in your issue, what is the issues. Among this, first two or three will be a major problems. If you are correcting this, 80 percentage of problems will be solved. So that means, so where I have to work, in which place I have to concentrate to correct it. See, for example, this relative frequency I wanted to correct it. Where I can correct is this first 3 point. So if I am wrong fittings, if I am able to work on it to correction, means it may not be able to correct this, because around the 80 percentage you can see around the 80 percentage only depending upon dimension out over surface finish and loose joints. These are the things will be considered 80 percentage of errors. So this 80 percentage of errors will be corrected, means that remaining all will be corrected. So that is the why. So 80 percentage of problems because of three parameters. So these three parameters I need to correct. So that is why the Pareto diagrams will be starting from highest error points to lowest level of errors. So that means from starting high to decrease low. This diagram, Pareto diagram, will help you to understand which is the major problem making in that in your scenario. Whatever the problems I am facing in that which is the highest thing, then you have to work on it. If you are able to correct it here, then automatically it will be start to reduce the errors or minimization of errors in the other parameters too. Then in the case, the Pareto diagram will be help to identify which is the three factors I need to, not only three factors. So first few factors, around 80 percentage of errors or correct problems may be solved. That will be help of Pareto diagram. So the Pareto diagram also like a bar diagram, but it is a histogram, but it is in the decreased manner it will be there. So which is the highest problem creator will be the first one, lowest problem percentage creator will be in the last. So from starting to it is decline. So then I can easily understand where the problems are able to solve. So 80 percentage of problems may first three defects it comes. So then I have to work on it. This place I have to work and correct it. These things. This is the things called as Pareto diagram. Then another one tool is called as flowcharts. Normally, the flowchart will help you to understand the steps involved in the process. What are the processes there? Employees understand how they fit into the process. So if you are doing in the manufacturing, you may not be need to be every day to check the process. But if you are able to others to work in the particular place, then you need to prepare that standard operating procedures like a stepwise program in the flow chart. If you are able to present, then everyone will easily understood, and they will be fit into that to place to work. See, for example, today if I am working manufacturing at tablet, everywhere daily I am working means I no need to verify any document. I routine, I can go and prepare as per the steps involved in that. But today I am working, tomorrow somebody is going to be working that place. Then what I have to do is I have to correct it that. How I will correct it that? So that we need to everyone fit to work in that particular place. For that, you need to create that SOPs or like a standard operating procedures, or like we have to prepare a standing operator procedure to identify these problems. So what is the problems? So one by step, first step you have to mix these two ingredients, then next to this, next to this. Then if it is a flow chart is there, everyone can easily identify the process. When the process understanding definitely will improve the quality. Many times I'm from the first year I'm telling that when you can understand the process and product knowledge, what is the I'm able to produce a product knowledge, these two are having very very essential. Product knowledge and process understanding will give quality product. So that is why everyone to your staff member, everyone to understand by means of like a preparing a standard operating procedure or flow charts, easily to understand that to what is the steps involved in the production, or what is the steps involved in the problem solving conditions. That can be incorporated into that everywhere. Then the train the people whoever may coming into the picture, then they will understand where I can carefully work in that. So it may be a 10 steps or 15 step or 8 step, 6 step. Among the sixth step may be a tough task. Then you need to give more importance to this place. You have to give some indications. That indication will guide the people to make a better quality. That is why these other flowcharts are very very essential. Previously I explained that scatter diagrams, no, this is the positive correlations already I said that. So here why I am here telling that the relationship will be understand by statistical analysis. You can predict the statistic analysis. So what the relationship between the factor A and B, if factor A will be X or factor B will be Y. So normally I said no, whenever I increase the speed, that particle size will be decreases, while in the experiment of preparation of nanoparticle or microparticle anything. So in that's a theoretical prospect. So any factors, then in the case A and B have a positive interaction. Here X and Y I discussing the relationship between factor A and B, that is X and Y have quality relationship, positive relationship. That means that it will be keep on in increasing manner. Then second one is negative manner. It may start negative manner. See, when I am able to curtail the problems, able to reduce the problems. So if I am increasing the efficient people to work in the industry, it should start decline the errors happening. So that means experienced people, if I am appointing to work in the problems where it's happened, so that they will be, I'm increasing this number of staff number increasing, that is experienced staff, then automatically it will decrease the errors. So minimization errors decline. That is negative correlations. No correlations. So you cannot conclude that this and this have positive or negative interaction. It may have both positive as well as negative interaction in the scattered. The many places it will be graphical representation. It will be that. So that it may not be one way, that is either increasing or either decreasing. So it may scatter values will be getting. So that means it's no in relationship between factor x and y, that is a and b, so it doesn't have any impact on other factors. So in that case, these two factors doesn't work together to improve a quality. So this understanding will be help for this where I can work, how I can work in that place. So these are the 7 tools given by Ishikawa to control the quality. So control 7 quality control, that 7 quality control tools, they may call the 7 TQM tools. There are 7 in the Six Sigma, TQM, everywhere we are using. Any industries, I said, any industries, quality control people need to work to ensure the quality in the first scenario. Nowadays, every industry, everyone is responsible for to produce quality product. So that is why we need to incorporate these 7 tools. So this is the point we need to consider. These tools will help to understand the quality perspective, how it is happening, where I can, which tool we may help you to understand the problem solving. That is the 7 tools. So now so far I discussed what is meant by quality, then what is by total quality management, then what are the benefits, what are the merits and demerits, then uh, what is meant by quality by design. Quality by design is the quality achieved by design, not by the things. So that means it's a quality by design approach. When it comes into the picture, from 1940 the gurus started. 1950s the gurus initiated, Japanese only initiated the quality perspective, then Americans followed that. When the American come to the Japan, the in response of the Americans, Japanese also work together for the enhancement of quality. In that, one person named called as Ishikawa, that Ishikawa only developed 7 QC tools, 7 QC tools, quality control tools. What are the tools in the things? Already I discussed that the 7 tools: check sheets, then histograms, then Pareto chart, scatter plot, control chart, cause and effect diagram. That the cause and effect diagram may called as Ishikawa diagram or fishbone diagram. So these are the text and all are given for your better understanding. But this is the way you need to work. Everything I explained. So the histograms is very essential to understand this. What is the checklist you are getting? Check first one is check sheet. Check sheet is the database of every product. What is the product? What is the data you are getting? That is entering into the some document is called a check sheet. To understand the check sheet, what it says, then histograms will be helpful. When the histograms is able to generate, then you can understand that what is the status of quality of product, where your product falls into that, whether all the product able to manage in the 94%, 95% significant intervals, or some errors, sometimes some low levels, sometimes high level margins it may fall. That is also you need to understand. That is the control charts. It's nothing but so low levels and high levels will be there. In between that level, if your product falls, that is your product may not be accurate, but it will falls in the controlled manner. It is in the controlled manner. If it is in the controlled manner, I can utilize this product, maybe produce a quality product. The control chart will be helpful. That is the way we need to go for this all the thing. Then flow charts, Ishikawa diagram. If you want to draw a Ishikawa diagram, you need to discuss with your all the members includes of technical, non-technical, your co-workers, employees, authorities, all put together, sit together, and create a brainstorming session on the particular problems issues. Then list out the points. Then list out the points. You have to correct it commonly. What is the point is that should be taken into the account. Then apart from that, what is the problem? I need to fix it. Then there you have to work on it. And this is called as critical parameters. This is called as critical parameters. The critical parameters, by changing, then it will be altered the response. That is called as determination of factors, response, factors and response relationship. That will be given by some diagrams called as scatter diagrams, 3D surface plots, then interaction graphs, contribution plots. Number of plots graphs are there, but this one scatter diagram, if it is factors x increasing, its y is increasing, that is positive relationship. If x is increasing, y is decreasing, negative relationship coefficient. Then if x is increases, y also may sometimes increase, sometimes at same level, sometimes it decrease. No concluded information about the correlation is called as scattered diagrams. This is non relation, having not having a good relationship or positive or negative relationship with the particular individuals. That is factor A and B. So when able to identify these parameters, I am very confident to not to have the relationship between two factors. So these are the 7 tools will be implemented. If able to correct these 7 tools, implement into your organization, 95% of problems may be solved. That is by this they happen. So now we'll go. So exam point of view, you need some material that's given here. What are the quality gurus? It may ask you. You discuss in detail about the quality gurus, what their philosophies, what their concept. They may ask you. So here, I have given 7 gurus: Walter A. Schwartz, then Edward Deming, Juran, and then Armand, then Crosby, then Taguchi, then Ishikawa. These are the people we consider as a quality gurus. Among these 3 gurus are very, very essential. This is Deming, Juran, Crosby. These 3 are we are need to be discussed. Then others also not important, not meaning that not important. That's all these 3 are major rules in the total quality mean, but of the 3 are inclusive of Ishikawa rules and regulations. What they given by the Ishikawa, it's incorporated into that somewhere, some points it will come to the picture. So these are the 7 peoples we called as quality gurus. So first, this Shewat we need to say he is the PDCA developed. He is the person developed PDCA. What is meant by that? Plan, do, check, act. This PDCA also followed by other way, that is SDCA, that is plan, design. You have to plan for your experiment. What that is comes in the picture I said. So yeah, my product, how it should be. Then based on that, I have to plan for that. So plan your experiment, that is design will come to the picture. Plan, then do the experiment, then check whether it is correct, whatever the what I planned, it is whether it is available or correctly it is there. The check, then it will be go for act, whether it will be allowed or not. But the same thing may be performed in the industry or wherever the thing. SDCA in the standardized standard, do, check and error. Standard means it's a one, everyone following the same conditions, rules or methodology is called a standardization. So if I able to produce a standardization, then I can go for this. Strongly influenced by Deming and Juran. This is PDCA will be followed by everywhere. This is the first person that Stewart given the ideology of PDCA, plan, do, check, act. this emphasis, the cycle will continuous improvement. If you want to perform continuous improvement, then you need to follow this terminology: plan, do, check, and act. The every industries. So I said that every this all quality parameters, it's a development of pharmaceutical product development they planned. Not only a pharmaceutical product development, in some industrial development process they performed. It may be a software, automobile engineering, or anything, but we need to incorporate into our situations. So that is why we are studying this plan, do, check, act given by Stewart. So, as I said, among the 7 gurus, 3 gurus are very, very, very essential. These 3 gurus given some statements. We need to compare these 3 statements. So that I will be follow the some slides. These are the 3 gurus. Among that, Demings given the theory of 14 points. What they be like Crosby also given some informations, but we are following now Juron triology. Triology we are following. He is giving that Juron given 3 things: QP, then QI, then QC. Juran given 3 point. So what is meant by QP? Quality planning. Then second one is quality implementing. Then quality control. Quality control in the sense controlling. It's whatever that we saw in the Ishikawa that will be coming. That is why that Juran and Demang both are very much emphasis in this Ishikawa. So as I said, 3 things I compared here. Some points you need to understand that. So here you can see definition of quality conforms to specifications, confirmations. So Crosby says that you have a standard protocols, that are procedures. If it conforms, so it's everything fall into that. That is called as definition of quality. But Deming says that predictable degree of uniformity and dependability at low cost suited to the market. That means, what is that? When I am performing an experiment, predictability, what is my product output? How should it be? That I am able to determine. That is predictable degree of uniformity. That is Deming insist. But Juran says that fitness to use, fitness for use the consumer. When the consumer can be used, the product is quality, the enhanced efficacy, that is performance, decrease the side effects, safety. Person is that is called as
Excuse me,
quality.
sir.
Sir?
Are you changing the slides?
Yes, sir.
No, it's not changing, sir. It's
Where
in
it-
4 only.
Huh?
Fourth slide.
Fourth slide in the sense, which slide, sir? You are not able to see the.
Yeah. It's not changing.
Oh, sir. Now you able to see the images, sir?
Yeah, now I can see 3 people that gurus.
Yes. Oh, so far you are not changing the slides,
No,
sir?
no.
Oh, sorry, sir. I see. If ever.
It's okay. But
Oh, sorry, sir. Okay, sir. Now I think now you're able to see those slides changing.
yes, sir.
The
Yes,
3
sir.
quality gurus comparing. Oh, so some beautiful images. I think given sir some graphs and all.
Yeah, we are
I think.
missing it.
Oh, okay. Okay, sir. I'll share the slides, sir. After this, anyone where to share this slide, sir?
Can
You
you
can.
please email us?
Okay,
Otherwise,
sir.
you put your
Yes,
email
sir.
ID in the chat box. We will
Yes, sir. Yes,
contact
sir.
you. We
Okay,
can
sir.
share.
Okay, sir. Okay. I'll share the slides, sir. It's exam point of view. They need to write it. So that is why I given prepared the things. What the discussion is there, I think they may understand these discussions. Okay, sir. Now these are the points we need to consider. So actually, definition by quality differs by person to person. The gurus. The first Crosby says that only the specification is satisfied, it is a quality product. But Deming says that you need to predict your end product. That is, whatever the specification need to be predict suitable to me. But Juran says that the combining of two specification fitness will be fixed for that. What is the final product? If I am able to produce, it is completely satisfied to the persons who is the involved in the consumer. So they have satisfied the consumer by means of quality, consistency, and the efficacy and safety product. So that is given by Juran. The another one point he can the structure you see. Some points I am discussing in this structure you see. He given 14 steps to quality improvement steps is our Crosby. But Deming says that 14 for managing the quality. Then Juran says 10 steps for quality improvement. But this Juran 10 points only we are now following by triology. Three things is three concepts he is giving. One is quality planning, quality improvement, then quality control. That we will discuss. But the points will be vary person to person. Then see another one is the performance standards you and motivation for. Crosby says that zero defects. We want to a product with zero defects. But others, Deming says that quality has many scales. Maybe a various of scales will be there, but critical parameter is zero defects. That is given by the Deming statements. Juran said avoid campaigns to the perfect work. So that means you cannot produce a quality product all the way. All the products may not be exact quantity or exact quality will be the consistency, but you need to perform a controlled manner. That is says by Juran. Then you see, sir. Then another one is statistical process control. Here, Crosby says that rejects the statistically acceptable levels of quality. So only the remaining place. So if I am able to produce a product where statistically what is significance, I have to accept it. Then remaining things I have to reject. So the Deming says that statistical method of quality control must be used to produce. So that means when I am using a statistical design, may produce a quality product and also able to reproducibility. So Deming insisting to use statistical methods to design an experiment. Juran also recommended the statistical process we need to incorporate. That is why, so the quality by design is an approach of giving a statistical tool. Cost of quality. Here, that Crosby said that quality product you need to produce. For that, you cannot be compromise the cost. So not a cost involved in this. But Deming says that no optimum continuous improvement, that cost of quality will be increased, he says. But that Juran also that quality is not a free. There is an optimum you have to spend for the enhancement of quality. So that point will be one person to another person. It is different. It's changing. So these three gurus are totally involved in this development of total quality management. This all total quality management in the development of their industrial expertise areas like automations, software industries, or drug development industries, or that can be adapted into our situation, whatever it may be, healthcare or hospital or pharmaceutical development, wherever the possible, I can use these things. So purchasing of goods, that is given very important statement that when the problem of EVA arises through the CMA, critical material attributes, that is what are the products input is that is clearly explained, that is uh, raw material, what the input factors I am able to give, that is directly depend on the quality output. That is what is the raw material I am using in that will be responsible for the output of the quality. So the quality and in raw material, what's the goods I am using have a direct relationship. All the three gurus are state that a quality product is essential for the quality output products. So this is the way they are given. Three gurus are given. So here, and one more thing is the Deming's 14 point I'm giving. This purely self-explanatory. Only single word is there. So I think you can see first one is create constancy purpose to improvement product and service. Constancy, that is consistently you have to produce a quality purpose. Then adopt new philosophies, not only a improvement of existing one, new ideology you need to incorporate in your things. Then depends of mass inspections, quality audit. So that means you need a person to incorporate into periodical checking. So mass inspection you need to perform to correct it the where the yeah, problems is arises. Then end the practice awarding business of the price tag alone. Only, not only a price tag you may not be considered. So he's giving, so that Deming giving, you need to focus on your quality aspects by compromising the price in increase in if your product is quality, you need to enhance the price, no problem, you need to enhance the quality because it will be suitable to the consumer satisfaction. So that is also you need to consider the low cost product for production, but also you should not compromise the quality perspective is telling. Then another one is some important points you think is there, the institute training. So when the person, if you are appointing whoever comes into the your organization, you need to give a quality training to create the environment. Whoever is responsible for the quality, he can work or serve in every place, not only HR team, not only QC, not only place, wherever he goes, he able to work. For that, we need to create, already I said that we need to create flow chart where the problems is solved. There he can focus. So that type of things institute need to create the training for the particular peoples. They eliminate numerical codes. Sometimes you should not given in the point of terminology, clear terminology you should use, so not in the coding words. So that should not be allowed in the work areas because some people's may not be aware of the coding terminology. Some industries may have following still coding terminology that will not be suitable for the total quality management product development scenario. So these are the things, very essential points given by Deming's 14 points actually. So here still Demings and Jurans both are together given a detailed quality programs, but all incorporation of Ishikawa things. Ishikawa rules 7 total quality management they are incorporating. So based on that, the Juran and Deming given the guidelines that both the Juran and Deming, the guidelines will be followed in the total quality aspects. Among this, Juran, Joseph M. Juran, is a person who created a quality aspect by using statistical design of experiments. That is why we are following the Juran's concepts now. The Juran considered as a three major areas. One is quality planning, then quality improvement, and quality control. These three are the major area he is focusing. So that means he developed the concept by three concept only. One is quality planning. Second one is quality improvement. The third stage is quality control. Then where I can see, you can in this graph you can easily say that when I can quality planning in the starting stage. So when I am doing any experiments, first I have to start initially. I have to plan and do the experiment. So first I have to plan the process for preparing to meet your quality goals. That when I am planning for the product preparations or any situation, that end product should be clear identified areas. That is your product, end product, you need to identify, that is explain that explicit requirement, that means systematically you have to think it that which is my experimental output going to come. I think that is very critical parameters for you to understand that. So when I am planning a experiment, I have to, it should be reflect on the quality of the products. So for example, if I am preparing a nanoparticles, that particle size should be nano in range. So if I am telling that, so nano particles is, everyone knows 0 to 1000 nanometer is called as nano products. So if I am telling that I want to produce a nanoparticle from 5000 nanometer, if I am preparing, it's not fulfilling the goals. So that is why, which is the method, which is the experiment I am able to produce a less than 1000 nanometer, that I have to plan and work. So that is the called as planning, quality planning. So you need to so prepare accordingly. What is your expert outcome? That is, they may call it as target quality product profile. Target quality product profile. So target product quality profile. How it should be? You have to be very clear understanding. So that what is by planning the experiment, what I am going to get, that product clear details you should understand. Then according to that you have to plan your experiment. That is called as quality planning. So the second point, quality improvement. So I planned an experiment. I need to perform an experiment. That is when I am step by step, I need to improvement. I have to process wherever the process of improvement. I am doing an experiment. When I am performing an experiment, I am getting a data sheet. That is here the quality control will come to the picture. So where that all terminology, I said no, that all graphs. So first one is sheets. Second thing is sheet and the histograms. Then Pareto charts. Then control charts. Then the box charts. Then flow charts. Then Ishikawa diagram. This all will come to that to understand whether the product I am improving the stages, whether it is in the controlled manner or not in the control manner, unacceptable levels or unpredictable levels. It went means then it's alarm. I need to work on that particular step. Then I have to improve the place. Then identify the right people to place in that particular place to reduce the issue problems. What is happening above the control levels? It went. That is the called as quality control stage. So that is why that Juran given triology three things. One is quality planning. I have to plan the and perform the experiment according to what is the output of the product. So that is my product output, how it should be. I have to be very clear. For that, I planned the stepwise programs involved. In the stepwise programs, where the problems may arise, I have to identify by quality control tools. That tools name called as TQM7 tools. That I shown seven tools. What are the tools is there already? I explained that tools will be incorporated. Then the tools will give you anything controlled parameters is deviation. Then you need to take action. Take action in the sense a particular person identify the who is able to decrease the level to the controlled manner, that can be very easily identified and it will be minimize the it will bring to the control level. That will be a very essential point. These are the things we need to work accordingly, will be the correcting the stage levels. So these are the Juran's terminology. So Juran given three terminology: quality planning, quality improvement, and quality control. But the quality control purely based on Ishikawa methodology. So once again, I'll show the slides of all the control charts. I think now only I came to know that these are the things not possible, not shown the slides. So on the era of the Americans who went to Japan, I think you can see the diagram. Now you able to see the diagram, sir? Picture, sir? Anyone answer?
Yes, sir. Yes, sir.
Now you can see this Edwin Deming, Joseph Juran, and
Yes, sir.
Armand. These three
Yes.
people went to Japan for quality aspect to create. Based on their response, three people came to the picture, that is Ishikawa and other two, Taguchi and Shiago. But the Ishikawa only given that quality control guidelines, this called as TQM tools. TQM. These tools used in Six Sigma, wherever the guidelines comes, total quality and QC tools, they may call it as QC tools. So the graphs that Ishikawa given a diagram to understand the process and process parameters response and parameters, this called as fishbone diagram. Now I think you can able to see a diagram like a fishbone. That is the your problem will be in the right side in the fish head. Then problem, what are the problems into come to the picture will be in the left hand side. This is the parameters. I said 5M and 1NE. That is 5M measurement, materials, methods, manpower, machines, and environmental condition. These may classify in general, not no need to be in the same manner for every situation. You can write your problem in the right hand side, your parameters will be in the left hand side. You can, according to that, you can prepare your own cause and effect diagram. Any industries, anywhere, if you want to start the process to understand the process condition, process parameters, you need to draw a fishbone diagram or cause and effect diagram. So these 7 tools given by Ishikawa, what are the things? Check sheets, histograms, scatter diagrams, control charts, run charts, Ishikawa diagram, and parameter diagram. This I explained once again. I'll show the just charts only. So checklist, we have to do another charts in the next class. I will show that histograms, like it will be like this, like a bar diagram only. But bar diagram will be different groups. If you are comparing, that will be a bar diagram. If a same group, you are segregating by group wise, is called as histograms. That difference you need to understand. This all can be any type of softwares can go for histograms or anything. One of the beautiful is Minitab software is available to use this histogram graphs. This is the scatter graphs. Scatter graphs in the two way I showed. Another place also I shown. This is the, you can see here also share the positive correlation between X and Y. When it start increasing, it is called as a positive relation. When the green color it shows, when I'm increasing the x-axis, it start decreases. That is called as negative relationship. Then I don't have any relationship. That is conclude evidence that when I'm increasing x-axis, then y-axis sometimes decreases, sometimes increases, sometimes same places. No correlation between factor A and B. This will be identified by scatter diagrams. Scatter where my data are present. That is called as scatter diagrams. So this I discussed three in the scatter diagrams. 3 points I can identify. One is it is having positive interaction or not, negative interaction or not, or interaction is there or not. Interaction, no interactions. So that is the three things I can identify. This is called as scatter diagrams. Then another one diagrams, it's a control chart. This is a very important one. Control chart, you can easily see this upper limit and lower limit. This all the products may not be a same result produced, but it may vary slightly. That in the level of control and lower levels. If it is touches the control level, here you can see if where the point is goes out, then in that case it is you have to control your the problems where that you need to identify your you have to focus, you have to concentrate. That place you need to reduce your problems to control level. That is will given by the control charts. This will be help to understand that whether my products are prepared within the control limits or not. Then another one is same exactly to the control chart, but the levels won't be there. Lower level and higher level may not be there in that. That is called as chart. Normally, the time management, how much time to reduce for batch to batch preparation may be identified by this tool. Then another one is Ishikawa diagram, same lab diagram only. I said 5M1E. So this is commonly used 5M1E, but you can create your many number of factors which is related to your response. You have to make it that. How can you identify that response is whether really involved in this changing of response? That identification is called as critical parameters. This factor identification based on brainstorming session. Three people sit together and discuss about the particular product is called as brainstorming session. Really in detail about discussion of that. Then Pareto diagrams. This graph you see, Pareto diagrams, it's like a bar diagrams, histogram, but it will be in the decreased order. Then these Pareto diagrams will clearly indicate that normally 80-20, 70-30 chances there. So that means what is that? First 80% of problems, if you consider this relative frequency is the problem, 80% of frequencies problems will start because of these three problems. If I able to first three problems able to correct it, then all the problems will be solved out. That is the things this identified, which is the things which area I have to work to solve the problems identified by Pareto diagrams. That is why the Pareto diagrams play significant role to identify and rectify the problems happen in the things. Any industries, any organization implementing the 7 tools definitely will be very useful for the reducing 90% of quality issues. So that is why the Pareto chart is very, very essential. So then other flowcharts, it's a sequence only. I said very clearly, step by step, you have to make it in the graphically, systematically. Nowadays, everyone doing a flowcharts methodology. That is why I'm not shown here. Flowcharts will help you to identify what the steps you need to more focus, because may not be possible to the same person for all the days to work in the same area. So everybody will work in that place. The rotations or cycle, it may change over that conditions. Everyone should understand which steps I have to more focus, where the problems may arise. That will be helped by the flow charts and all the things. These are the things will help to understand and rectify the problems in our industry areas. So I think another points I discussed the beautiful program. This plan, do, check, and act. I think this diagram very, very, very important diagram. We are following Juran as well as Deming, all influenced by this Shewart methodology only. Shewart only said that PDCA, plan, do, check, act. Now the PDCA is turned into a SDCA, standard, do, check, act. So that means this check is a very critical parameter in the quality control aspects. That means you need to check that not a quality product should not reach the customer or not to reach in the market or patients. That is why very, very essential. Particularly, pharmaceutical industries have more focus on quality control and quality assurance, since the product is very direct relation to the human health. That is a harm to the human being. If it is mistake, it may be a harm to the human being. So that is why more focus on this. The check parameters will be Ishikawa points we are planning. The plan and do the experiment will be Juran's implement. The current TQM I am telling. Among the 4 quarter, plan and do the experiments by Juran terminology, triology, the check by Ishikawa, that is also incorporated in Juran, but that is why Ishikawa majorly we are planning. Then be able to find out where the problems are arises. We need to take the action to control to the bring to that. This is the things we very important point. I'll discussing. I think I'm not able to show the images. So the quality gurus, the continuous. The three quality gurus are very essential. Crosby, Deming, and Juran. These the four are very essential persons in the philosophy concept making. Among this, we are more focusing Deming and Juran. In that, Juran's only currently we are following what they are discussed. I shown that comparison. The exam point of view, you need this. The Deming's points maybe they may ask 14. Juran introduced three parameters: quality planning, quality improvement, and quality control. So the quality control, as I said, this Ishikawa programs, then quality planning and improvement by Juran's. That is comes into the picture of QBD, quality by design, not by a chance. Quality by design, I can make it. When I am planning for the design, what is the relation to the exact product profile? What I need that end product profile. According to that, I have to design an experiment. Then I can achieve the experiment by control parameter strategy. With this, I think today we will close. Then I have another 10-15 slide, that is cost of quality. That will be in the discuss in the next class. I think next class they given in the Thursday. uh, Anything anybody want to ask, you can just a few minutes we can discuss if you want. Okay, I'll share the slides to your coordinator or director, DD director. If you useful, you can use this exam point of view. You need this slides for your preparation and all the things. Then we'll meet on Thursday. Huh? Thank you.
Good afternoon. Hello. Good afternoon. Can you hear me? Good afternoon. Dr. Pawan Sharma. Good afternoon, Dr. Arvind Gupta, sir. Good afternoon, Nivedita. Good afternoon. Good afternoon. Good afternoon. Dr. Lavanya. Can you hear me? Dr. Lavanya, can you hear me? Louis Buzzer, can you hear me? Louis Buzzer, can you hear me?
Yes, sir. Yes, sir.
Yeah,
Good afternoon, sir.
fine. Good. Let me thank you. Let's wait for another 5 minutes. I think that will.
Okay, sir.
I have to thank you, Louis, for sending me the scanned copy.
It's okay, sir. Doesn't matter.
Yeah. We'll start after 5 minutes as some more people are joining. So we'll start. Shiva Ranjani, are you ready, sir? Lavaneshri, Tanya, Vidyadharan, Lavanya Vijay Kumar, and 4 others who are joined. Welcome to the afternoon session. Let me start. Last class, I discussed about the entire syllabus of 5 units for you. Now, in the group, thanks for Brother Louis or somebody else who started the group, I have forwarded a couple of information to you. One, I have forwarded a book on inventory management, which is of a very good material for you, which you can use it for further reference. Do not for the examination now, number one. Number two, today being uh, International Alzheimer's Day and also International Pharmacy Day, I congratulate all the people who are involved in the healthcare services and distribution of medicines, manufacturing of medicines, and prescribing medicines across the country. I congratulate all of you, and I also would like to tell you that you have to be very, very careful in the prescription of the drugs. I later take up the topic as we go ahead in our program. Would that be all right? I want somebody to respond from the group other than Louis.
Okay, sir.
Okay. I think Mr. Brother Louis, Dr. Lavanya Tanya Agrawal, Vidya Dharan, and Lavanya Vijay Kumar, Shiva Ranjani, the other 5 people, they should respond. Only when it's interactive, it will be very interesting for all of us to learn. Okay. Today's topic, I have broken down to 6 major areas. Number one, what is the principles of logistics management? I repeat, those of you who are having a piece of paper, you can make a note of it. It'll be easy for you when the examination is coming. I also forwarded to you information, whether I'm entitled or not, I don't know, but I thought I should share with you that the exams are for all of you is going to start next month, 25th. So we should prepare ourselves for the lessons, for the syllabus coverage, for the reading, for doing some assignment and work in the online class, and also an outline for the projects which are supposed to submit as the final year students. The modalities of how to submit your project has been forwarded by the directorate from Pondicherry University in a 30 pages booklet, which I'm sure all of you would have received. You have any doubts on that, I'll allot about 10 minutes time at the end of the session for you to clarify what exactly the product should have. If other professors have shared with you, fair. If it is not shared, I'll be in a position to share happily with you the importance of the project and how you should go about in doing the project, and how to start the project, how to select the topic, what should be the research methodology you should follow, what are the references you should have. All these points will be dealt, say, for example, by 2:45 by me. So with this, I'll start. The principles of logistics management started from the ancient Greek time when the war broke out. When the war broke out in Roma and other countries, they used to move the goods, whatever is wanted for the army people, and the material, the food, the necessary items for fighting the army were moved. That's how the logistics word has started way back sometime. But today's condition with the event of 1991 liberation, privatization, and globalization, logistics have become a very, very important topic because I'm in Bangalore, it's a happening city. So you just order for something online, it comes in 10 minutes time. They call it blink it. That by the time you blink, within 5 minutes the product is delivered at home. That's the way the product is now moving. The supplies are made. So is it not important for all of us who are in the healthcare department to know the logistic plays a very, very important role in modern world? What exactly is the definition of logistics? If you want to get good marks in the examination, you have to mention the correct definition for logistics. Yesterday, at the introductory department of the introductory class, I told logistic is nothing but place of manufacturing to place of consumption. But the management guru, who is also the consultant of 500 Fortune companies, the respected Philip Kotler, Professor Philip Kotler, whom I had the occasion to interact with him in Chennai way back about 12 years back when he launched a book for marketing for South Asian perspective and also H2H marketing, two books he launched for India. At the time, I had the occasion to meet him in New Meridian to interact with him. So I respect the guru on marketing, Philip Kotler. According to the Kotler, logistics means, I repeat, planning, implementing, and controlling, planning, implementing, controlling, and the flow of materials from the place of the finished goods to the origin for utilization or for the usage. Again, repeat a scientific definition by Philip Kotler for logistics management. The definition given by is planning, implementing, and controlling the flow of materials from the finished goods area to the area of consumption. This is one quote. So whenever you want to get good marks in the examination, you have to quote the third party evidence. Third party evidence here in the case is according to Philip Kotler. Okay. Is one definition. Is the definition clear for all of you? I will
Yes, sir.
Yeah. Yeah, Luis, Brother Luis, only you are joining. The others are not participating.
Yes, sir. I said yes. I responded, sir.
Yeah, okay, it's okay. Maybe post lunch session, they must be okay. Now coming back to the second definition, which you can always to want to get good marks, especially as evaluated senior people like me, want to get good marks, you have to think of the other source of definition. The second, so it's also the textbook. I'm not giving something which is not in the textbook. It is in the textbook. So it is according to American Council of Logistics Association. They say, I repeat again, according to American Society of Logistics, they say efficient, cost effective, storage, dispensing, sending it across to the right time, the right people, the right time, and in the right direction. I repeat the second definition of logistics. American Council of Logistics says efficiently, cost effectively storing, dispatching, sending to the right time, right place, to the right people is a scientific process which is known as logistics management. These are the two definitions you can give. Normally, these sort of questions will come in part A. It carries about 6 marks. So you can give some examples to get some good marks. For example, you place an order in, Tata have started medicines called one type, I think one, right? Table one or medicine one, something. So you place the order, you get it fast. You have online medicines available now for supply on against prescriptions, and that's all done in the same way, right people, right time, and the right direction for the right price. That's what American Association of Logistics says. Okay. Then you have what is the purpose of this logistics? Now, having understood what is the definition of logistics, what is the purpose? The purpose and the process is very, very clear. Right direction, right time, right moment, right people. That's it. The medicine should reach. Okay. Functions, the next point, what I would like to talk about you in the afternoon will be the functions of logistic management. First, when you want to dispatch any drug, first you have to do the invoicing. The second one is once you invoice and send the product, you have a latest now system called tracking system, which you all of us know about it, tracking. And the delivery standards is very, very important. How the product is packed, how the product is forwarded, is it the -5 temperature, or it is going to be just like that packed and sent across? Depends on the type of medicine what we are going to use. If we're going to use vaccines, it should be maintained certain degree, and I'm sure that should be known to you. So these were the functions of logistic management. 3 points: invoicing, tracking, and delivery standards. So having discussed these two, definition, functions, and principles of purchase management, then we have to have how to purchase the medicine. Then we have to have the tendering process. Tender in government hospitals are working. You go by 3 steps called open tender, closed tender. Open tender means ask for openly the quotation from the suppliers and buying the medicine. Closed tender means a particular period is given to you. You can quote for the medicines, your supply rate, everything, and it is open in the front of all the suppliers at this particular given transparently without anything, and that medicine is picked up. How it is picked up? That is called L1, L2, L3. L3, L1, L2. There is lowest quotation number 1, lowest quotation number 2, and then L3. Lowest quotation number 1 will be picked up and it will be supplied. This happens normally for normally used drugs like paracetamol, APC, and other things, but it is not applicable for life-saving drugs. Life-saving drugs, companies won't prefer to quote L1. They quote the price what they want. For example, when I was working for a company called Sandoz, I used to supply synthozione, methergine, especially in OG ward. Without synthozione and methergine, you cannot function. So I cannot be supplying it L1 rate. I will supply to the rate which company wants. So you, as the people who are going to administer the hospital, you have to think there are 2 different types. Essential drugs cannot be compromised. The commonly used drugs, which can be, it may be generic, because now we have got branded versus generic. The current thing which is going on now in Indian pharma companies is branded versus generics. So brand means you have to pay for it. Brand means, for example, a drug. To develop a drug, minimum it takes about 7 to 8 years. The 7 to 8 years, it should clear the 4 clinical trials part, and then only the drug will be cleared for human consumption. Such an amount of effort and scientific work is carried on in R&D department. So you cannot quote the price what you want. You have to buy the price at what the company is giving. For example, I'll quote my own example. About 22 years back, 2 decades back, some of you are not born, we launched a product in India called calcitriol. Have anybody heard about calcitriol in the group? You can unmute and answer me. Calcitriol.
Vitamin D3, sir.
Vitamin D3. Who is the answering, please?
Shivaranjani, sir. Yes, sir.
From where?
Sir, I am working as staff nurse in IGMCRI, sir. Kadirgamam.
Kadirgamam. Good. Calcitriol is not vitamin D3. Calcitriol is a further derivative of a direct substituent of the deficiency. What is it? What is that drug? Having answered Shivaranjani, thank you very much for answering. What is
Thank you, sir.
What is the diagnosis or prognosis of this deficiency of calcitriol?
Calcitriol, sir.
Yeah.
No idea, sir. I know about vitamin D will give rickets deficiency. That only I know, sir.
Okay. This one thing what we discovered when I worked in a company. It was discovered by Dr. Sylvia from USA. It is known as osteoporosis.
Sure, sir. Sure.
Osteoporosis is one where postmenopausal women and men above 60 will get, because
Yes,
the calcium is available in the blood, which will be absorbed by the person, because we don't take the intake as a calcium. So this particular disorder or disease was discovered, and it's known as osteoporosis. Now, for that, alpha D3 has come. Calcitriol, the product what I launched was calcitriol in Pondicherry. Since you are from Pondicherry, I can quote for the benefit of others. I had conducted 3 programs in Pondicherry, one at New Medical Center, Dr. M.V. Sundaram, and Dr. Sivadasan, and other one was Dr. Ilangovan's clinic, I think so. I had the BMD meter, which was brought from Japan. We kept and checked the BMD bone mineral densitometer of women based on tablets, which were costing 20 rupees per tablet. We gave it free for patients for 20 days and asked them to buy it later. The name of the drug, brand name was Roche Calcitriol. Then subsequently Alpha D3 has come now. A lot of calcitriols have come generic. Branded and generic, you have a lot of difference and cost wise. So coming back to this, you have to know from where you are going to procure your drugs. So you have to know the source of supply. The source of supply can be taken from, it's not in the textbook, but can you make a note of it? You have 2 books where you can, 3 places where you can always refer. Some of you must be knowing it, some of you may not be knowing it. The one is known as OPPI. Have you heard about it? Lavanya Vijay Kumar, Satish Kumar, Lavaneshri, Ivarani. I'm just observing how many of you are participating. In the regular class, we'll have 25 marks. In the distance mode, we don't have, unfortunately. But still, I will monitor. I have a list of the names given here by the directorate. Vidyadharan, are you there? Okay. Now, OPPI is Organization of Pharmaceutical Product Producers of India. OPPI. Kindly make a note of it, those of you are having a small piece of paper. OPPI, Organization Producers of Pharmaceutical Company of India. The next one is IDMA, Indian Drug Manufacturers Association. From these 2 websites, you can find out what are the drugs which are available. Now, latest, about 19 years before, we introduced one more for the benefit of doctors and the benefit of pharmacists and benefit of everybody. We produced a book called SIMS. So you can refer the SIMS book, find out what is the generic. I'm sure some of you must be knowing about it. It should be available within you, right? So, Vidyadharan, can you answer me? OPPA and IDMA. These are the areas from where you can get this information about where you can procure. So I tell you, again repeat, for the commonly used drugs, you can go for the lowest quotation of annual tender, quarterly tender, emergency purpose. Plenty of things are available. We are working in the hospital. I don't want to go in detail to that. Suppose I'll tell you my personal example to share with you. There was some time back the severe epidemic pandemic disease came up, which is from the rat bite from Gujarat. Can anybody name the disorder?
Leptospirosis.
Yes, Louis, sir.
Leptospirosis, sir.
There were rat bite,
Plague,
rat bite.
sir.
Yes,
Not plague,
yes,
sir. Plague.
yes, excellent. Plague. What was the drug which was only available for plague disorder treatment? Good, Shiva. Shiva Ranjani is answering
Thank you,
properly.
sir.
And, yeah, it will be Shiva Ranjani, madam.
Yes, sir. Yes, sir.
Whatever answer you are giving, it will be useful for others who are listening, or it's also recorded. So you can get it in the website also later. Plague.
Sure, sir.
Plague disease
Uh,
originally
yes,
started
sir.
in Gujarat. I was stationed at Hyderabad. I was made as SOS person on behalf of the company. There were 2 lakh tablets available. Only 2 products were effective against plague. One was tetracycline. Tetracycline was manufactured only by 2 companies at the time: Terramycin from Pfizer and tetracycline from IDPL, Indian Drugs Pharmaceutical Company from Hyderabad. And their manufacturing capacity was very low. The second drug, which is very, very effective for that, was cotrimoxazole. Yeah, some child is answering. Good. Okay,
Sorry, sir.
unmute.
No, sir. He's interfering. Sorry, sir.
Cotrimoxazole.
My son, sir.
Yeah, no, fine, fine, good. He's likely to become a good doctor again, like you. So, or a
Thank you,
pharmacist.
sir.
One is cotrimoxazole, that is Cetron and Bactrim. These are the 2 drugs, cotrimoxazole and tetracycline. So these sort of endemic epidemic problems, when it comes, you have to procure the medicines and on a war footing, right? Now dengue, for example. Dengue is now prevalent in Bangalore. Now 14,000 cases have been reported in the morning times of India. I've seen Tamil Nadu 4,000 cases. Alarm has been created. There is no treatment for that except that we have to give platelets. Have we got enough blood banks in the country? Have we got enough blood banks? Not only blood bank, you have to give only platelets for dengue. So have you got the blood separator in different parts of the hospitals available? Are they being kept in sterile places? Or they got a dictionary of donors available? So when you want to procure this blood, is again not procured. It's all voluntary services, right? You have a donor, they give you. So you have to find out from where you can get the drug. I'll give another interesting example for all of you in the afternoon. We're going to sleep, maybe in the afternoon time. All of us know about Amitabh Bachchan, the big B, right? When I was acting in a movie called Coolie, it's a blockbuster some time back. It was action movie. When I was lying down in a what do you call steel one, he got hurt very badly. When he got very badly, the nervous system and he got hurt in the intestine and got affected the nervous system, the brain, and the nervous system could not coordinate with that. That is known as the disorder is known as myasthenia gravis. What about this myasthenia gravis? In this
Autoimmune
myasthenia,
disorder.
yeah, myasthenia gravis, there is only one drug which is available in the world market. That was our product, rose from Mastinon. The Mastinon was not available. Another incident which I can give you, because I'm giving you from Cinefield, because all of us are quite familiar with the Cinefield, so you know about it. The other one is Smita Patel, the actress who died of post-delivery fungal infection. The drug was not available, furosemide, antifungal infection. I'll coming back to the point of logistics. I'll come back to the story again. The product was not available. The trade name of the product is known as Ancotil. Amitabh Bachchan at the time was MP and a good friend of Rajiv Gandhi. It was uproar in the house. We had a lot of restrictions on multinational companies. We had FDI. We have the only high caliber products can be manufactured in India. Other products has to be manufactured only by Indian companies, not by foreign companies. I was working for a company called Roche, that's from Switzerland, major giant, only research products. So this product was not available. We are questioned, and I was flown to Delhi, and I was asked to appear before the committee why this drug was not available. Then we had to tell them that when your average percentage of investment in India is above 76%, we can manufacture, otherwise we have to import the drug. So Mastron was imported, Ancotil was imported. In the bargain, Samita Bachchan survived, whereas Smita Patel, we lost her because of post-fungal. You can just a case study again. You can Google search. Post-fungal delivery complication, Ancotil was. Again, one more drug is not available for Parkinsonism, dopamine, Medopa, that's the trade name. It is not available. So after 1991, things have changed. The patent regime from process patent to product patent, everything has changed. Now most of the drugs are available thanks to the government of India's initiative, thanks to the government of MCI, the control department. Now most of the drugs are available. Okay. Now some of the drugs are not available. Now I want to ask some of the uh, participants here, how do you import a drug? It also comes under logistics. I said the drug should be available in the right place, in the right person, from the right source. Anybody is aware of from where and how to import the drug? What is the procedure? Logistics. It is not in the textbook. But you should know. No answer means all are silent or not want to listen to me.
So we have to follow FDA policy, sir. Import policy that will be available.
Yeah, imported
FDA,
policy.
Food and Drug Administration.
Yes, excellent. What is that code number? Good. I want you to type it up for the benefit of all. If you can help me out, it is
Yes,
IMP.
Yes, sir.
Shivaranjan madam, are you
Yes,
a
sir.
gynecologist or are you a, what is your specialized in what?
Sir, I can't hear you, sir. I am a nursing officer. I am a nurse, sir.
You are not. Good, good. Now you are the most important person. Okay.
Thank you.
Nurses play a very important thing. Can you just type it out for the benefit of all in the chat box? I'll just dictate to you. There is drug control department has given one particular website which we have to go and download, and we have to use Form D if you're working in a teaching institute, if you know about it, and you can import. What is that? There are about 14 conditions laid down for importing a drug which are not available in the country. Okay. So can you just type it out? It's known as 10 drug control
Sir, actually,
department.
I'm not good in technology, sir. I'm just joined, sir.
Okay,
Try.
no problem. Nothing more. It's known as IMP
Okay,
slash.
sir.
I'll in the notes later to you once I complete. The problem is now, I'm sure all of you must be knowing that you have got exams of next month, 25th. We have to complete our syllabus. We have to complete
Sure,
our
sir.
revision. We have to complete our project. We have we are working on a very tight rope walk, right? We have 5 units, and 5 units have to be finished. We have to revise it. We have to have PPT to be prepared. I want you to work out on the exercises that are given in the textbook, and all should pass out the exam very well. That's one of the reasons, right? Since you are a
Sure, sir.
nurse, I would say this is as I correctly said, it's in the drug control department. REG. First one is IMP, Indian Medical Practitioner, slash REG slash 200711. I repeat for the benefit of the sister, form
Yes,
number
sir.
10, IMP REG
Yes, sir.
200711. What are the factors? What are the factors which they have to? Yeah, you are clear.
Yes,
Audible.
sir.
Yeah.
Yes,
What are
sir.
the things they ask? They ask the name of the institute, a letter of authority that is from the superintendent of the institute or the dean, whoever it is, and what is the registration certificate of the DL number you have got in the institute, and form number 8, form number 9, and you have to send it across to central drug department, and they will be in a, that comes under Ministry of Health, which is not there in the textbook, but you should know. It's a logistics, how to import a drug. Right. I also sent today as a World Alzheimer's Day. I have sent one information in the group for all of you. Have you seen that? Mankind Pharma. Are you part of the group, Sivaranjani?
I will check, sir.
Yeah, yes, you can check up later. SpiceJet has been totally, 2 SpiceJet planes have been decorated with the importance of medicines, being International Pharmacy Day, and the importance of using the drugs properly, and the importance of active pharmaceutical ingredients. All the 3, and the availability of the drug in the respective place. Because you should know, Mankind Pharma is one of the company which has played a very vital role in COVID period for supplying some of the accessories for COVID for nurses, as well as for doctors, as well as for emergency wards, including oxygen, which is the company which helped in during COVID period in producing the vaccine. They worked 3 different shifts. 10,000 crores was supplied and given as an advance to the government, from the government, to supply to manufacture the drugs, samples, and vaccines, which you all got on time. Anybody in the class can inform me what is the name of the company? COVID, which is a life-threatening disorder throughout the world, shook the entire world. We all were part of it. 3 years. No answer. The answer is Serum Institute of India. Not only it captured and catered to the entire country, it catered to 64 countries in the world, and we got a good brand image for supplying the COVID vaccine. Covaxin, that's the name of the brand. I'm sure you would have heard it, they would have used it in the Rajiv Gandhi Institute, right, in Pondicherry. Covaxin is the name. Serum Institute was the company from Pune which manufactured and supplied for not only for India, for the entire country, in the world. Where Pfizer, where our competitors, they were charging $2,500 per vial, whereas we gave it free to all in India. Corporate social responsibility. So this takes you to the point of logistics for medicines for importing, which are emergency medicines, which can be imported. And the next point, what are the precautions we should take in logistics management? While supplying the medicines, from the place of manufacturing to the place of usage, what are the precautions we should take? Anybody? I think only I am talking, others are listening, or otherwise they logged in and got. Gopalakrishnan, Lavanya Vijay Kumar, Satish Kumar, Avanishri, Yorani, and 7 others. The precaution is mainly because maintaining the temperature, what is supposed to be stored, number 1. Number 2, drugs like which are coming in Schedule H.
Expiry.
Okay. Yeah, Louis brother, tell me.
Drug expiry, sir.
Sir?
Expiry of date. That's
Yeah.
lifespan of the drug.
Yeah. Lifespan, date of manufacturing, date of expiry, that has to be checked. Good. Next. Drugs like the fentanyl.
Vaccines, sir.
Fentanyl.
Vaccines like that.
What I mean?
Sir, vaccines like a drug has to be maintained temperature suitable for that, sir, to maintain the potency.
Excellent. What happens if there is adverse drug reaction, ADR?
ADR, sir, ADR will happen if the drug is not maintained at a correct temperature, sir.
Okay, now what is the antidote for that?
Oh, which drug, sir?
Any drug. Name
Any
the
drug, steroid will be given, sir, for ADR.
Okay.
Immediately, DEXA, like that, sir.
Immediately use dexamethasone. That's the correct thing.
Hydro, yes, sir, I will dexamethasone or else hydrocortisone.
Hydrocortisone. That's the two things. Good. Excellent.
Yes, sir.
Excellent. I think, Shiva, that's the thing you have done with pharmacology thoroughly. So,
Sure.
Louis Brother, what Shivaranjan Madam is telling from Pondicherry is when you have adverse drug reaction, maybe because you have not stored it properly, maybe because you are not kept it the place where it's supposed to be, you have a this is not there in the textbook. This is about experience I'm talking about, adverse drug reaction, ADR. So it has to be taken care of. So in the first unit of your logistic management, please make a note of it. First, I discuss with you, I repeat, the principles of logistic management is the first one topic. Next one is definition and logistic management of Philip Kotler as well as American Society for Logistics that I discussed. And then tendering process I talked to you, L1, L2, L3, that's normally used for the commonly used drugs like APC, paracetamol, other things. Whereas high-end drugs, where life-saving drugs, we cannot go by the lowest quotation. We have to go by what the company says, because 16% of the cost of the medicine goes only for research. And if a company comes out with a product, it takes about 7 years for a research product to come out. So this is the reason why the drugs which are coming are high priced. For example, how many of you have heard about interferon? Interferon. I'll give you a prelude where you can understand and tell me. There cannot be two infections simultaneously happening in the body of a human being. A viral infection, a bacterial infection. There is some sort of a mechanism within the body which can protect from one infection to other infection, that is known as interfering mechanism, which led to the discovery of interferon, which is now used in cancer treatment. Have you heard about 5-FU, 5-fluorouracil, some time back? Interferon, you have heard about it, alpha interferon. That's a drug which is useful for the treatment of oncology, especially cancer patients. And neopogen, that's another drug, Neopageon, neopogen. It's all discovery of the latest research available. And unless and until the research and development goes in a pharma industry, we cannot get new medicines and new treatment for all these things. So as certain amount is spent on research, that's the reason the prices of these drugs are kept very high. So you cannot go in the vendor selection L1, L2, L3 process. Okay. Now, next point which I would like to share with you is how do you make the payment for you import a drug? How do you make the payment? Will you pay it in Indian currency? Will you pay it? What is the way to follow? Which is there in your textbook? Methodology of payment. There is a 6th point with your first unit. Anybody has opened the book and read? And I thank Louis Brother who has sent it across to me so I could go through the book in the morning and I could make some notes and then I am sharing it with you. Have you heard about LOC? Not line of control.
Letter of credit.
Letter of credit.
Letter of credit.
Letter of credit, excellent. Letter of credit. So when you give your invoice from the exporter to the importer, you give it to the bank, they pay on your behalf and your bill is cleared and you get your medicine. Letter of credit. One is one. The other one is, other way is you can even send foreign currency and get it immediately. That is foreign currency again convertible. You have to go to the bank and ask for the reason and then tell give your Indian money, they convert it into foreign currency, because now earlier we never had European Union currency. Italy was lira, and different currencies were different countries. Now we commonly about 5 currencies are available: US dollar, Australian dollar, Singapore dollar, Euro currency, Euro, and China some other currency, and that's it, accepted currency. So you can get all these currencies in the different banks, and by quoting the authorities letter from the department of yours, maybe the head nurse, or maybe from the head of the department, maybe from the RMO, from the medical superintendent, or from the dean academics, you can get this, go to the bank and get your invoice cleared by LOC or by paying the foreign currency bill. And the import documentation is very, very, very important. Important documentation carries 14 points, which I told in the beginning of the class, that you have to Google search what is that is given by the Government of India's, I repeat, 1 second, give me that, the letter, which is Central Drug Standing Committee. Central Drug Standing Committee, which comes under Ministry of Health. Get to the website and you can get the import process of the essential drugs which are not available in India, which are not manufactured in India. It is also part of your lesson. Suppose somebody from IIM, suppose some other professor from some other college sets a question paper on this, he should not be at dark. That's the reason I have given these particular examples of how to import a drug. To sum up, before we go for the case study and before we go for the project lesson, what are the points? I'll just repeat again. First, the principles of logistic management. It started during the war, during the Roman period. How to move the goods, how to move the armory, everything. And the definition for logistics by two. One is Philip Kotler, the other one is by American Society for Logistics. Then the principles of the logistic management, and how do you procure the medicines from where you want, what are the steps to be taken, and next we discuss about what are the precautions you should take while receiving the medicine, storing the medicine, utilizing the medicine, and what are the antidotes available. And then we thought about vendor selection. In vendor selection, we talked about L1, L2, L3, if it's going to be a commonly used drug, if it is going to be a life-saving drug, which is an expensive drug, which has to be imported, then we have to follow the Form D from hospitals and institutes, and we have to get the authority signature. There are 14 necessary documents which you have to prepare to get the drugs. Then we also discussed about LOC, letter of credit, for getting your drugs without paying money. The bank gives you and you can give it. And we also discussed about some of the drugs which were not available at the time of 1991, 1996. At the time, I given two examples which you can Google search about the incident what has happened to Amitabh Bachchan while shooting a movie called Coolie, and Smita Patel, a famous actress from North India, who passed away during a post-fungal infection after the delivery period, and coating. And I also talked about dopamine, Medopa. And I also talked about some of the drugs which are available because of the research and development, which is a part of pharma company, that's about neopogen and interferon. So these are some of the important areas which I touched upon in the morning. Now, a case study has been given you in the textbook about Coca-Cola. I just want to throw some light on how to describe and write the case study in the examination hall, because it carries 20 marks. In your first unit, at the end of the book, you have got Coca-Cola. Am I right? How many of you have gone through the book? Coke. Brother Luis?
Sir, Coca-Cola. Yes, sir. Yes, sir. Coca-Cola.
Yes, sir. I gone through, sir.
Yeah, Coca-Cola. Coca-Cola was originally, can you believe it? I'll just give you a brief history about it in the textbook. It was started by a retired army officer called Pemberton. Pemberton is a retired army officer. He's from Atlanta in USA. The army officers normally used to drink because of the climatic conditions that they're working. And he, after retirement, he couldn't have much of money. He prepared a concoction or concoction, what do you call, sometime back. Some of our doctors used to give a small child a decoction like no mixture. They used to give everything, Sarvaroga Nivarani. So, like that, he developed something, and he was trying to sell that particular product, which is a little bit of intoxication. And only one pharmacist bought this for $310 in those days. And he got the patent. And that one is now is known as Coca-Cola, world's number one brand. Now, what is the logistics they have? That's what their question is in that. They have different parts. They have, I think, they are operating in 75 countries in the world. What is the logistics? Have you traveled abroad? Any one of you? I think Louis' brother would have gone to Dubai, or you would have known. Coke is given along with the KFC food. Everything wherever it is there, Coke is given free along with that, not mineral water, right? Madam Sivaranjani's sister, this Coke is given along with the food what you are having, one way. How the logistics goes is they have multi-locational manufacturing units. For example, in India, they have 7 manufacturing units. In Palghat, they had the closure because of the union. One is at Tirumuri side, one is in Bangalore. They have about 7 or 8 manufacturing units, multi-locational manufacturing unit. That means different parts of the country, so that the cost of transportation, you have studied in second semester CB analysis, cost benefit analysis. The transfer of goods from one place to another place comes down because of different manufacturing units in different places. Am I right? So this is what the case study is about. So in logistics, if you have multi-locational manufacturing unit, now let me give an example. All of us know the Apple computers. Apple computers, how many countries are contributing for the finished product? Anybody? Apple phone, sorry, Apple mobile phone. There are 7 countries involved in manufacturing of Apple mobile phone. One is Korea, South and West, and then next is USA and Germany, and the finished products are manufactured now, going to be starting in Hosur near Bangalore. 10,000 people are going to be employed, and according to today's Times of India news, the manufacturing capacity of Apple mobile phone is going to be from 4 million to 40 million by year 2025. See the growth. Why? Because we have the important ports, we can export it fast, and the infrastructure development is happening in India, so that by road, surface, everything, we can reach the destination of the port fast. So in logistics, what counts the last is infrastructure, mode of transport, and the speed in which we can move the goods. So the company has selected India as a center for moving the goods from here to Australia, to Singapore, to UAE, and other places. So it becomes very convenient for them to transport, it costs less. So infrastructure plays, this is not there in the book, but can you make a note of it? Infrastructure plays a very important role in logistic management. Am I clear? All the 10 points are clear? Any doubts before we go to the project guidelines? Yes, please. Satish Kumar, Lavanya Sri, Lavanya Vijay Kumar, Gopalakrishnan sir, where are you? I think all of them are just logged in and then went away. Thank God. Sometime back, 20 years back, 18 years back, we had what do you call attendance register. Unless until you attend 80% of the classes, you will not be allowed to sit for the examination. Things have changed now. But for the first semester onwards, we are starting activity-based learning process where you have 30 marks. Unless until you participate, you will not get the 30 internal marks and you will not pass the examination. You're all lucky. Now we have come to the fag end of it. Let me come to how many of you are aware of how to go about doing the project? Brother Luis can come out first, and Shivaranjani sister can come out. Dr. Lavanishri.
What is the question, sir?
Regarding,
Repeat it.
regarding project, sir, project guidelines, sir.
Yeah, yes.
Relevant, we can select the topic, title of the project relevant in our study, sir.
Okay. Have you done MSc Nursing or BSc Nursing?
I have done MSc Psychology, BSc Nursing I have done, sir. BSc
Okay, where
Nursing,
you
and I did
nursing?
in our Mother Teresa, sir. Mother Teresa, Pondicherry.
Oh, Pamath is upon zero. Okay, fine. Dr. Gopal is a convener. Fine. Okay.
Yes, sir. Gopal, sir.
Good. And psychology from where?
Madras University, sir.
Good. And the correspondence.
Sure, sir. Yes, sir. Under correspondence.
Fine. Now you tell me relevant topic number 1.
Guidelines they have given in the website, sir.
Okay.
The titles are like a review of literature, hypothesis, everything they have given clearly, sir, regarding that. Regarding guide selection, they have told a guide can be selected on ourselves, sir. In our department also, PG faculties.
Okay. So you would like to have your guide in your own department. Good. How about
I am trying.
Louis Burger? Good. What is the topic you selected, Shiva?
Just now I selected a plan to select a knowledge
What do you mean?
assessment, sir. Knowledge
Assessment of what?
biomedical waste management among nurses, sir.
I think already I have seen this project in AVMC when I came for a ethical meeting.
Okay,
It should
sir.
not be just check whether there should be no plagiarism. Knowledge
Okay, sir.
management of nurses in what?
Biomedical waste management, sir.
Biomedical waste management. I think I've seen it that in AVMC and Jipper also. I've seen. Okay, good. You have a local
Duplication
guide.
should be avoided, sir. We have to select a new topic, sir. It's better, sir.
No, you decide. You decide on the topic. Your guide is there. You have a proper guide. It's good. You should be a qualified guide. Okay.
Yes, sir.
Louis brother, how are you? You have worked abroad in Dubai.
Yes, sir.
What is the topic you have decided? Hospital management system.
We study on work safety for employees in radiology department. In
You work in
diagnostics.
radiology department. Then,
Yes, sir.
What is the topic you feel that is the ideal thing? The effect of radiology on the human being.
Work safety for employees in radiology department.
Okay. You have a guide there, Velu, for you.
No, sir.
Okay.
I have to.
I am free to offer my guidance to you on the different topic, whatever you suggest. You can put it in the group, my name and other things. Those who are interested, they can always contact me, and I can give some of the relevant topics. Not necessarily that you should be only confined to radiology, because imaging has come up now. Now AI has come up very fast. So
Yes, sir.
telemedicine has come up. There's so many things we can do, right? We can always think
Yes, sir.
about it. And your project carries 100 marks. You know about it. And as Shivaranjani has told it, you should have minimum first introduction of the topic what you're selecting, and small write-up on what's happening in the department with the topic what you have selected, how you are going to have the research methodology, the type of sample collection, whether it's going to be simple random collection, it's going to be cluster sampling, it's going to be interview method, it's going to be a questionnaire method, observation method. There are different types which you have studied in research methodology in second semester. You can incorporate. Then you have to use the tools like ANOVA. In the hypothesis, as you said, you have to prove one thing wrong. Null hypothesis and hypothesis. So you have to prove it wrong, one hypothesis. And then you have to analyze the data, what you collected from different people. But my problem, which I feel for you, is the time limit. The time limit is not even 40 working days. The 40 working days, you have to prepare 5 subjects, right? Out of which one subject I'm handling. And the one subject which I today handle is the logistic management. I would request all of you to go through the book today. Then you will remember. Today itself we go through. I know you will be busy, but go through the book today. Then you will be in a position to understand the subject properly. That's what happens when you have a distance mode of teaching or online teaching. Is person-to-person contact is not there. So this is one of the drawback of online teaching, but you can still manage. Just go through the textbook which you have received, and you will be in a position to understand. And case
Sure,
study, regarding case study, always read the case study twice. not once. Read the case study twice. Read, read, read. I undergone the training in IIM Ahmedabad about how to do case study research. So read, read, read. What exactly the questions asked? 2, 3 questions they ask for. Relevant answer to that you answer in the case study. You can get 14 to 15 marks if you can answer properly using the some of the terms what you have learned in management, in principles of management, in economics, in strategic management, in HR, in change management, in recruitment, training and development, in knowledge management. So many 30, I think 28 subjects you have studied. So you can pick up some of the quotable quotes and then try to quote it in the what do you call case study. You'll be in a position to get good marks. So with this, if you have anything else, I can clarify. I think in the project, one thing which I would request you to kindly incorporate is recent references on the topic what you have selected in the literature review, not 2008 and 2009. Literature review, recent one. I may be visiting Pondicherry between 16 to 19 to UVMC for a day for the protocol clearance for ethics board. I will put it in the group. Maybe some of you are in the Pondicherry can contact me and then get it clarified. The dates have not been finalized. I'm telling you next month, 16 to 19. Within these 4 days, one day I'll be there in IVMC and half a day I'll be in JIPMA. So I can clarify some of the doubts if you have anything on the project. Literature review is a very important one. And the most important thing is what exactly you have found out from your research. The observations, the suggestions, the recommendation. 3 important points. Your observation, your suggestion and suggestion for improvement, and you leave it for the other researchers to do something because for want of time you may not be in a position to do complete research. You do it for the benefit of the other researchers, and always acknowledge in the front page the director of the institute, your people who have helped you out, the guide, and your family members, every other person you can just acknowledge and take 3 important certificates. One is a declaration by you. It's a study by me, conducted so and so for the reason so and so, signed by you, and declaration by the guide. And third page, the profile of the guide if it is needed, if it is, can be added, fine. If it gives, fine. Otherwise, his qualification name stamp should be all right. These 4 points in the first page we see. I repeat, your declaration, guide's declaration, guide's qualification, and the particular route map of a project has to be classified. Page 1, number 2, page number 80. It has to be put in a proper form, right? I want to refer to page number 30 of your literature. I just go to page number 30 and see. It should synchronize. To arrange the project in such a way, in a sequential way, easy for us to find out and easy to evaluate your project. Okay. Wishing all the best, and we will meet tomorrow to take up the second unit. First unit, all of you will read. Tomorrow, you'll have 5 minutes, quick question answer session to understand whether you understood what I have discussed with you, all of you. Thanks a lot for spending the time in the afternoon with me. Have a nice day. For the next lecture to join, and I think Professor Gopal is going to join. All the best to you. Thank you very much. Thank you very much.
Thank you, sir.
Thank you.
Thank you so much.
Thank you very much.
Good afternoon. Am I audible?
Good afternoon. Yes, ma'am.
My slides are visible?
Yes, ma'am.
Okay, thank you. Today, we will be discussing about health programs. In that, some of the health programs like reproductive and child health program, and then national program for prevention of diabetes, hypertension, cancer, that program, and then tobacco control program, and at last, mental health program. Today we will be discussing all these four topics. Coming to reproductive and child health program, the reproductive and child health program, approach has been defined as people have the ability to reproduce and regulate their fertility. Women are able to go through pregnancy and childbirth safely. The outcome of pregnancies is successful in terms of maternal and infant survival and well-being, and couples are able to have sexual relations free of fear of pregnancy and of contracting diseases. So it mainly deals with pregnant women and also childbirth and also some contraceptive methods. So in this, there are two phases of reproductive and child health program, phase 1 and phase 2. First, we will be discussing about phase 1 now. The major intervention under reproductive and child health program, phase 1 is essential obstetric care. Next one is emergency obstetrics care. Next is a 24-hour delivery service at PHC as well as in community health center, and then medical termination of pregnancy, and then control of reproductive tract infection and sexually transmitted diseases, and last is immunization. And then essential newborn care, and then diarrheal disease control, and then acute respiratory disease control, prevention and control of vitamin A deficiency in children, and prevention and control of anemia in children. So first coming to essential obstetrics care. So what do you mean by an essential obstetrics care? It is in this, it provide early registration of pregnancy within 12 to 16 weeks, and then provision of minimum 3 antenatal checkups by ANMs or by medical officer to monitor progress of the pregnancy and also to detect any risk or complications so that appropriate care including referral could be taken in time. And then it also includes provision of safe delivery at home or in an institution. And at last, it also provide 3 postnatal checkups to monitor the postnatal recovery and to detect complications. Then coming to emergency obstetrics care, complications associated with pregnancies are not always predictable. Hence, emergency obstetrics care is an important intervention to prevent maternal morbidity as well as mortality. So under this RCH program, it usually strengthens emergency obstetric care kit. There is one kit available. So it will strengthen that kit, and then equipment kit, and also provision of skilled manpower on contract basis. And then coming to 24-hour delivery services, it promotes institutional deliveries, and provision has been made to give additional honorarium to the staff to encourage round-the-clock delivery facility at health centers. Coming to medical termination of pregnancy, MTP is a reproductive health measure that enables a woman to opt out of an unwanted or unintended pregnancy in certain specified circumstances without endangering her life. The aim is to reduce maternal morbidity and also mortality from unsafe abortions. The assistance from the central government is in the form of training of manpower, supply of MTP equipments, and provision for engaging doctors trained in MTP to visit PHC on fixed dates to perform MTPs. Next one is control of STD as well as reproductive tract infection. So under this RCH program, the component of STD control is linked to HIV and AIDS control. It has been planned and implemented in close collaboration with National AIDS Program organization. The assistance from the central government in the and drug kits including disposable equipment. Each district is assisted by 2 lab technicians on contract basis for testing blood, urine, and other reproductive tract infection tests. Coming to immunization, the Universal Immunization Program became a part of this RCH program. Next, coming to essential newborn care. The primary goal of essential newborn care is to reduce perinatal and neonatal mortality. The main components are resuscitation of newborn with asphyxia and then prevention of hypothermia. Hypothermia is nothing but decrease in temperature, body temperature, and then also prevention of infection, and then exclusive breastfeeding for 6 months, and then referral of sick newborn. The strategies are to train medical and other health personnel in essential newborn care, provide basic facilities for care of low birth weight and sick newborn in district hospitals. Usually, children are more affected by diarrhea and respiratory tract infections. So, this program also helps in control of diarrheal disease control as well as respiratory disease control. In diarrheal disease control, ORS, there is an introduction of low osmolarity ORS and also zinc to the patient who are having diarrhea. And this addition of zinc could result in number and also severity of episodes and duration of diarrhea is reduced. And also deworming guidelines. And also the incidence of diarrhea is reduced by provision of safe drinking water. Next, coming to acute respiratory disease control. It is death due to pneumonia is very common among children. So the peripheral health worker are being trained to recognize and treat pneumonia. So the main drug kit is cotrimazole that will reduce the severity of pneumonia. Next, coming to prevention and control of vitamin A deficiency in children. It is estimated that the large number of children suffering from subclinical deficiency of vitamin A. Under this program, a vitamin A is given to all children till the age of 5 years. So the first dose is 1 lakh is given at the age of 9th month, and then the subsequent dose is given at 2 lakhs units, and it is given every year up to 5 years. Then coming to prevention and control of anemia in children. So iron deficiency anemia is widely prevalent in young children. To manage anemia, this policy has been revised. The infant from the age of 6 months onwards up to the age of 5 years are to be receive iron supplements in liquid formulation in doses of 20 mg, 20 milligram of elemental iron and 100 microgram of folic acid per day for 100 days in a year. So children between 6 to 10 years of age will receive iron in a dose of 30 milligram of elemental iron and 250 microgram of folic acid for 100 days in a year. And then children above this age group would receive iron supplement in an adult dosage. Next, coming to training of DIAS. In this program, DIAS should be how the DIAS should be trained. That also given in this program. A scheme for training of DIAS was initiated during 2001 and 2002. The scheme is being implemented in 156 districts. The districts have been selected on the basis of safe delivery rates being less than 30%. The scheme was extended to all the districts of states. The aim was to train at least one DIA in every village with an objective of making safe deliveries. So, what are all the interventions in RCH? One is essential obstetric care. Next one is an emergency obstetric care. Next one is 24 hours delivery system. And next is medical termination of pregnancy. Next is control of reproductive tract infection. And next is immunization. Next, coming to essential newborn care, diarrheal control program, acute respiratory disease control, prevention and control of vitamin A deficiency in children, and prevention and control of anemia in children. Coming to reproductive and child health program phase 2. The phase 2 was begun from 1st April 2005. The focus of this program is to reduce maternal and child morbidity and mortality with emphasis on rural healthcare. The major strategies under the second phase of RCH are essential obstetric care. It mainly deals with institutional delivery and also skilled attendance at delivery. And in case of emergency obstetric care, operationalizing first referral unit and also operationalizing PHC and CHC for round the clock delivery services and also strengthening referral systems. And then coming to other new initiatives like training of MBBS doctors in life-saving anesthetic skills for emergency obstetric care and also setting up of blood storage centers at first referral unit according to Government of India guidelines. So in RCH2 also it deals with essential obstetric care and also emergency obstetric care and also strengthening of referral units. So in essential obstetric care it deals with institutional delivery and also skilled attendance at delivery. And in emergency obstetric care it deals with operationalizing first referral unit and also PHC and community health center. So that's all about this program. Next, coming to Janani Suraksha Yojana. This is a national maternity benefit scheme and it has been modified into a new scheme called Janani Suraksha Yojana. It was first launched on 12th April 2005. The main objectives of the scheme are reducing maternal mortality and neonatal mortality through encouraging delivery at health institutions and focusing at institution care among women in below poverty line families. Coming to Janani Sishu Suraksha Karyakram scheme. This scheme was launched in 1st June 2011. It is a new national initiative to make available better health facilities for women as well as children. And then smaller schemes like Vande Mataram scheme that mainly helpful in iron and folic acid tablets and also oral pills and also TT injections in pregnant women. Coming to child scheme, this is an integrated management of neonatal and childhood illness. It has following services. One is pre-service IMNCI, next is facility-based IMNCI, next is newborn care corner, next is newborn stabilization unit, and last is special newborn care unit. First coming to pre-service IMNCI. So in this, it has been accepted as an important strategy to scale up IMNCI by Government of India and is being included in the curriculum of medical college of the country. So this will help in providing the much needed trained IMNCI manpower in the public as well as in private sectors. Then coming to facility based. So the facility based IMNCI is an integration of the facility based care packaging with IMNCI package to empower the health personnel with the skill to manage newborn as well as childhood illnesses at the community level as well as the health facility. It focuses on providing appropriate inpatient management of the major cause of neonatal as well as childhood mortality such as asphyxia, sepsis, low birth weight, pneumonia, diarrhea, malaria, meningitis, and severe malnutrition in children. The master trainers at state as well as district level are pediatricians from tertiary hospitals and also medical colleges. So next one is newborn care corner. So it's a space within the delivery room in any health facility where immediate care is provided to all newborns at birth. This area is mandatory for all health facilities where deliveries are conducted. As of March 2015, about 16,000 newborn care corner are operational in the country. Next, coming to newborn stabilization unit is a facility within or in close proximity of the maternity ward where sick and low birth weight newborns can be cared for during short period. So in addition to newborn stabilization unit, there is a newborn care corner. So it requires space for 4-bedded unit and 2 beds in postnatal ward for rooming in. Next, coming to special newborn care unit is a neonatal unit in the vicinity of the labor room in which it provides special care, that is ventilation and also major surgeries for sick newborns. So the minimum recommended number of beds for a special newborn care unit at the district hospital is 12. So what are all the criteria for admission in special newborn care unit and also in newborn stabilization unit? First, we will be seeing what are all the criteria for admission in a newborn stabilization unit. One is apnea or gasping. Next one is respiratory distress, that is rate is more than 70 per minute with severe retraction or grunt. Next one is hypothermia, that is temperature should be less than 35.4 degrees Celsius. And in hyperthermia, that is temperature more than 37.5 degrees Celsius. And next is central cyanosis, that is bluish discoloration of skin and mucous membrane. And next is shock, that is cold periphery with capillary filling time more than 3 seconds. And significant bleeding that require blood or component transfusion. Next criteria for admission to special newborn care unit. One is birth weight less than 1800 grams or gestation less than 34 weeks. And next is large baby, that is birth weight more than 4 kg. Next is perinatal asphyxia. Next is apnea or gasping. And then refusal to feed. And then respiratory distress rate is more than 60 per minute. Severe jaundice appear less than 24 hours and also it stains palms and soles. And then hypothermia or hyperthermia, and then central cyanosis, shock, coma, convulsion or encephalopathy, and then abdominal distension, and then diarrhea, bleeding, and also major malformation. So what are all the major highlights in IMNCI? One is inclusion of 0 to 7 days age in this program, and then incorporating national guidelines on malaria, anemia, vitamin A supplementation, and immunization schedule. Next is training of health personnel begins with sick young infant up to 2 months, and then proportion of training time devoted to sick young infant and sick child is almost equal, and then it is mainly skill based. So the main objectives of IMNCI are it mainly used to monitor sick as well as normal newborns. Coming to next program, that is Rashtriya Bal Swachhta Karyakram. It was a new initiative that is launched in February 2013. It includes provision for children's health screening and early intervention services through early detection and management of 4Ds. What are all these 4Ds? One is the defect at birth, then is disease in children, then it's any deficiency like vitamin deficiency, mineral deficiencies, etc. And then last is developmental delay that include disabilities, etc. So what are all the defects at birth? One is the neural tube defect, next is Down syndrome, next is cleft lip and palate, next is a clubfoot, development dysplasia of the hip, and then congenital cataract, congenital deafness, congenital heart disease, and last is retinopathy of prematurity. And coming to deficiency, what are all the deficiencies? Mainly vitamin A deficiency, vitamin D deficiency, and then anemia, and then severe acute malnutrition, and last is goiter. And coming to childhood diseases, what are all the childhood diseases? One is skin condition like scabies. Those who play in mud usually get these scabies, and then fungal infections and eczema. Those who have low immune power, they usually get fungal infections, and then eczemas, etc. And then otitis media, and then rheumatic heart diseases, reactive airway diseases, and then dental caries, and then conventional disorders. Coming to development delays and disabilities, what are all the development delays? One is vision impairment, next is hearing impairment, and then neuromotor impairment, and then motor delay, cognitive delay, language delay, behavioral disorder that is autism, and then learning disability, and then attention deficit hyperactive disorder, and then congenital hypothyroidism, sickle cell anemia, beta thalassemia, etc. So these are all the 4Ds that is included in this Rashtriya Bal Swachhta Karyakram program. Coming to RMNCH and A, that is reproductive, maternal, newborn, child and adolescent health. So it was first launched in 2012 June. That is the government of India, Ethiopia, USA and UNICEF convened the global child survival call to action. It was first started in Washington DC, mainly to end preventable child death through targeted intervention in effective life-saving intervention for children. So the main goals and target of this program is reduction of infant mortality rate to 25 per thousand live birth by the year 2017, and also reduction in maternal mortality ratio to 100 per 1 lakh live birth, and then reduction in total fertility rate to 2.1 by the year 2017. So it also include adolescent health. So what are all the adolescent health programs included in this? One is adolescent nutrition, and then iron and folic acid supplementation, and then facility based adolescent reproductive and sexual health services, and then informative and counseling on adolescent sexual reproductive health and other health issues, and then menstrual hygiene, and then preventive health checkups. So first is adolescent nutrition, that is iron and folic acid supplementation. The Ministry of Health and Family Welfare has launched weekly iron and folic acid supplementation, that is WIPS. So in this program, there is high prevalence and incidence of anemia among adolescent girls and boys. The long-term goal is to break the intergeneration cycle of anemia and also nutritionally improving human capital. The program implemented across the country, both in rural as well as in urban areas. So, administration of supervised weekly iron and folic acid supplement of 100 mg of elemental iron and 500 microgram of folic acid using a fixed day approach, and then screening of target groups for moderate or severe anemia and referring these cases to an appropriate health facility, and then biannual deworming albendazole 400 mg for 6 months apart for control of helminth infestation, and this is also a preventable cause of anemia. And then information and counseling for improving dietary intake and for taking action for preventing of intestinal worms infestation and also hand hygiene, etc. Coming to menstrual hygiene scheme, the Ministry of Health and Family Welfare has launched this scheme for promotion of menstrual hygiene among adolescent girls in the age group of 10 to 19 years in rural areas. This program aims at ensuring that girls have adequate knowledge and information about menstrual hygiene and have access to high quality sanitary napkins along with safe disposal mechanism. So the key activities under the scheme include community-based health education and outreach in the targeted population to promote menstrual health, and then ensuring regular availability of sanitary napkins, and then sourcing and procurement of sanitary napkins, and then training of ashas and nodal teachers in menstrual health, and also safe disposal of these napkins. Coming to home-based newborn care, there is a provision of essential newborn care to all newborns, special care of preterm as well as low birth weight newborns, early detection of illness followed by referral, and support to family for adoption of healthy practice by ASHA worker. What are the strategic intervention packages? The intervention has been divided into three categories. One is the essential, next is situational, and last is implemented. Health plan. All areas. Delay and also an essential category, that is balanced energy protein supplementation, and then periconceptual folic acid, and then maternal calcium supplementation, and then multiple micronutrient supplementation, that is iron, folic acid, iodine, etc., and then nutrition counseling. And next is counseling and birth preparedness, that is also an essential category. And last is prevention against malaria, that is situational, that is common in certain areas like certain. Coming to outreach or in sub-centers, that is antenatal screening for anemia and hypertensive disorder of pregnancy, that is pregnancy-induced hypertension, preeclampsia and eclampsia, and then antenatal screening for malaria, and then prevention and management of mild to moderate anemia, and then maternal tetanus immunization, and then adolescent-friendly health services like nutrition and reproductive health counseling, contraceptive insertion. Next, in health facilities, there is antenatal screening and management of severe anemia and hypertensive disorder of pregnancy, and also gestational diabetes and syphilis. Next is antenatal screening and management of hypothyroidism, hepatitis B, HIV, and malaria, and then adolescent-friendly health clinics. And then postpartum family planning services, which include intrauterine contraceptive devices, and then prevention of Rh disease using anti-D immunoglobulins. Next, coming to care during labor as well as childbirth. So in family and community, mainly there should be a skilled birth attendance and clean birth practice. And in sub-center, there is identification of complications and time by ANM, that is antenatal corticosteroid in preterm labor, and also antibiotics for premature rupture of membrane, etc. And then what are all the health facilities? One is emergency obstetric care, that is the basic as well as comprehensive, and then management so also antibiotics for premature rupture of membrane. In family and in community, there is delayed cord clamping that will prevent anemia, and intervention to prevent hypothermia, that is immediate drying, head covering, skin to skin care, and then delayed bathing, and then early initiation and exclusive breastfeeding, and then hygiene to prevent infection. In outreach or in sub-center, there is, we should give vitamin A at birth, and then neonatal resuscitation. And then in health facility, there is advanced neonatal resuscitation. And next, coming to care of healthy newborns. What are all the care should be given in healthy newborn in family and in community? That is home visits till 6 weeks by trained ashas. They should give counseling and also prevention of hypothermia, cord care, early identification of danger signs, prompt and appropriate referral, and also exclusive breastfeeding for 6 months, and then clean postnatal practice. In outreach and in sub-center, immunization like BCG, OPV, hepatitis B, and DPT. Now there is combined vaccine called pentavalent vaccine, and then health facilities. In health facilities, and then also all these interventions are being taken care. And then coming to care of small and sick newborns, In family and then in community, there is thermal care and feeding support is very essential. And then outreach, or in subcenter, there is an integral management using IMNCA and use of oral antibiotics, and then injectable gentamicin by ANMs to prevent sepsis. So completion of antibiotic course in case referral is refused or not possible, as advised by treating physicians. Coming to health facilities, one is gangrene mother care. That is very essential. That will encourage feeding and also improve weight gain. And then full supportive care at block and district level. That is newborn stabilization unit at block level and sick newborn care unit at district level. And then intensive care services at regional levels. That is assisted ventilation, surfactant use, and also surgeries. Coming to care beyond newborn survival, that is family and community, screening for birth defect and also failure to thrive and development delay, and then follow-up visits. That is also very essential. So in sick newborn care unit, discharged babies till 1 year of age and small and low birth weight babies till 2 years of age. And then coming to health facilities, there is newborn screening and then management of birth defects, diagnosis, treatment, including surgeries, and then follow-up of high-risk infant discharged from sick newborn care unit and small newborns for development management. So these are all the programs related to mother and child, that is reproductive and child health program, that is having two phases, phase 1 and phase 2. And next is Janani Suraksha Yojana, and then Janani Sisu Suraksha Karyakram program, and then home-based newborn stabilization unit, and then IMNCI program. And at last we saw about Indian newborn action plans. Next, coming to National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, and Stroke. So the major objectives of the program are as follows. One is prevention and control of these NCDs through behavior and lifestyle changes, and then it provides early diagnosis and management of common NCDs, and then build capacity at various levels of healthcare for prevention, diagnosis, and treatment of common NCDs, and then train human resource within the public health setup, namely doctors, paramedics, and nursing staff, to cope with the increasing burden of NCDs, and establish and develop capacity for palliative as well as rehabilitative centers. The various approaches such as mass media, community education, and interpersonal communication will be used for behavioral change, focusing on following messages: increased intake of healthy foods, and then increased physical activity, avoidance of tobacco and alcohol, as well as stress management. All these will prevent diabetes, hypertension, cancer, etc. What are all the activities at subcenter? Health promotion for behavior and lifestyle change will be carried out by organizing various camps, interpersonal communication, posters, banners, etc. Opportunistic screening of population above 30 years will be carried out using BP measurement and blood glucose by strip methods. And then suspected cases of diabetes and hypertension will be referred to community health center of higher health facility for further diagnosis and management. For screening of diabetes, glucometer optimum exceed, Optimum test strips, and auto disabled lancet are being produced at central level and provided to the concerned state as per their requirement from time to time. So then what are all the activity at CHC? It is mainly same, but extra text like lipid profile, ultrasound, X-rays, ECGs, etc. They are also carried out in community health center. And one of the nurse appointed under the program shall undertake home visits for bedridden cases and also supervise the work of the health worker and attend monthly clinic being held in the village on a random basis. And in case complicated cases of diabetes and BP shall be referred from community health center to tertiary hospitals, district hospitals for further investigation and also managements. Coming to activities at district hospital, NCD clinic at district hospital shall screen person above the age of 30 years for diabetes, hypertension, cardiovascular diseases to identify individuals who are at high risk of developing diabetes, hypertension, and cardiovascular for further investigation, and then detailed investigation will be done in respect of person. Those who are at high risk of developing NCD, they shall provide regular management and annual assessment of persons suffering from cancer, diabetes, and hypertension, and also people with established cardiovascular diseases shall also be managed at district hospital. They shall provide home-based palliative care for chronic, debilitating, and progressive patients. Apart from clinical services, district hospital shall be involved in promotion of healthy lifestyle through health education and counseling to the patients and their attendants. Coming to urban health checkup scheme for diabetes and high BP, the scheme has the following objectives. One is to screen urban slum population for diabetes as well as high BP, and then to create database for prevalence of diabetes and high BP in urban slums, to sensitize the urban slum population about healthy lifestyle, that is exercises, and then reducing salt and sugars, etc., and then stress management. And coming to that, blood sugar and BP will be checked for all and above more than 30 years and all pregnant women of all ages. And then NCD cell at the center, state and district will implement and monitor the national program for prevention and control of cancer, diabetes, hypertension, CVD, stroke in various states. Coming to new initiative under this program, one is it is helpful in prevention and control of rheumatic heart diseases, and also Rashtriya Bal Swachhta Karyakram. It includes 4D, that is disease, defect, disability, and deficiency. And then coming to integration of Ayush with NPCDCS, and then integration of RNTCP, that is tuberculosis control program, with NPCDCS to articulate a national strategy for management of TB as well as diabetic comorbidities in India. So, what are all the cancer services under national program? That is common diagnostic services, basic surgery, chemotherapy, and palliative care. At hospital, each district is being supported with 1.66 crores per annum for the following, that is chemotherapy drug for provided for 100 patients, and then daycare chemotherapy facility is being established, and then facility for lab investigation including mammograph is being provided, and if not available, and it is also outsourced at government rates. And then home based palliative care, and then support is being provided for contractual manpower through one medical oncologist, one cytopathologist, one cytopathology technician, two nurse for daycare. And then State Cancer Institute will provide comprehensive cancer diagnosis, treatment, and care services. And then 45 centers were to be strengthened at tertiary care centers to provide comprehensive cancer care service at a cost of rupees 6 crore each during 2011 and 12. That's all about NPCDCS. Next, coming to tobacco control legislation, the important provision of the Act are prohibition of smoking in public places, prohibition of direct and indirect advertisement of cigarette and other products, prohibition of sale of cigarettes and other tobacco products to a person below the age of 18 years, and then prohibition of sale of tobacco product near the educational institution, and then mandatory depiction of statutory warnings, including pictorial warnings on tobacco packs, and then mandatory depiction of tar and nicotine content along with maximum permissible limit of tobacco packs. What are all the main components of this program? One is public awareness, that is mass media campaign, etc. And then establishment of tobacco product testing laboratories, and then mainstreaming the program component as a part of health delivery mechanism, and then mainstream research and training on alternate crops and livelihood with other nodal ministries. And then monitoring and evaluation, including surveillance, adult tobacco survey, and dedicated tobacco control cell for effective implementation and monitoring of anti-tobacco initiatives, and then training of health and social workers, school programs, and then provision of tobacco cessation facilities. Mental health programs. The main objective is to ensure availability and availability of minimum mental health all in the foreseeable future, and also to encourage application of mental health knowledge in general healthcare and also in social development, and also promote community participation in the mental health services development and to stimulate efforts towards self-help in the community. The program strategies are integration of mental health with primary health care through the National Mental Health Program, and then provision of tertiary care institution for treatment of mental disorder, and then eradicating stigmatization of mentally ill patients and protecting their rights through regulatory institutions like the Central Mental Health Authority and also state mental health authorities. That's all about these programs. Any doubts regarding this program? Any doubt regarding this program? So we saw about reproductive and child health program, and then IMNCI, and then Janani Sishu Suraksha Karyakram, and then about NPCDCS, that is National Program for Prevention and Control of Hypertension, Diabetes, Cardiovascular Diseases, and Stroke. And then we saw about Tobacco Control Program, and then National Mental Health Programs. Till now, any doubts? Okay, thank you.